respiratory. Sideways. Apologies for that. Right, so, upper respiratory tract infections, right? You will see these all of the time. Right? It's very, very common. A little less common when everyone was wearing masks. That was nice. Um, it could be a combination of almost everything. Most upper respiratory tract infections are brought to you by a virus. So when they are treated with infection, antibiotics, eventually, um, it's not really doing anything. So that's why we have bugs, monster, antibiotic resistant into bacterias. Um, Spontaneous pneumothoraxes, right? They can pop up occasionally, literally. Um, Most of the time, it's seen in tall, thin men with long chests, right? So, you'll see it a lot in, excuse me, younger men who were like, oh, I was out playing basketball. All of a sudden, started having a hard time playing, right? Because they did that stretching. They jumped up, stretched their lung, and popped it a little bit. Um, every once in a while, if it's one of those things that happens a lot, it can be an ongoing issue. Then they'll know, like, yeah, I probably have a pneumo. Um, but pneumothoraxes can also be spontaneous, secondary to an underlying disease, right? We talked about the blebs that you see in COPD patients; those can spontaneously pop on their own and cause a pneumo. Oh, there we go. Especially during positive pressure ventilation. I One of the things we found, or I've found, is that a lot of the times you'll be ventilating a patient who's tubed, and sometimes firefighters get a little aggressive, and they can cause a spontaneous pneumo. Or sometimes you can get aggressive. It happens. A little too much epinephrine going on in the system, right? So, you will see all of a sudden the patient will be very difficult to bag. This is one of those times where you get to do a excuse me. Apparently, WebEx makes me sleepy. This is one of those times where you'll actually be able to get in there and do a needle decompression. I have encouraged three. I have never gotten to do one on my own, but I have had my own guys who had worked up arrests, and they said, "Hey, it's starting to get kind of hard to breathe." I'm like, "You're gonna decompress them then?" And they're like, "I can." I'm like, "I mean, yeah, like it's in your protocols. They're dead. No one's gonna question that one." So you ever have a moment in time when it's getting a little hard to breathe for a patient who is intubated, they might benefit from a decompression. So, most of the time, duo is relatively well tolerated if it's less than 20% of the lung. So there, I picked up a lady once who she had a history of spontaneous pneumos. She was at work and she's saying, you know what, it's finally getting too hard to breathe, even though she felt it go like 2 days prior. So most of the time, your hallmark sign or symptom is going to be that sudden onset of like focal chest pain. That focus is usually where they've popped the lung. You can also see subcutaneous emphysema, right? So those little air bubbles underneath the skin. That feels kind of like a Rice Krispies treat. So here's the optimal location for needle decompression. Okay. Um, so you're going to do it on the affected side, on top of the second rib. So when a patient's sitting up, generally that first rib, or on top of on top of the third rib, sorry. The first rib is right underneath the clavicle. So if you're having a hard time finding landmarks, right on the clavicle is one. Okay, then you're going to work your way down and find the spaces. Do not insert a needle for decompression on the underside of a rib because that's where all the nerves and vasculature is. So you don't want to slice and dice that with a 14 gauge needle. Um, in pediatrics, we use a smaller needle. We use an 18 rather than a 14 for needle decompression, but that when you get there a little bit more. But basically, not only you're optimizing oxygenation for that patient, you're also optimizing their circulation because as that pneumothorax starts to get worse, it's going to compress the heart and not allow the heart to fill. Hyperventilation syndrome. If I'm sure you all have seen this, right? Patients basically having a panic attack. Um, some sort of stressor has caused them to start breathing rapidly. And as they start breathing rapidly and deeply, they start to blow off too much of their carbon dioxide. Carbon dioxide floats around in your bloodstream as carbonic acid. So when you reduce that acid, you become alkalotic. So once you start screwing with your pH, it your body starts to respond appropriately. But as you start to hyperventilate and be more anxious, then the patients are able to control their breathing. Word. I'm sorry. It's like the Monday yawns. So basically, your entire care is based on trying to calm the patient down. Okay. This is, they used to do you put the patient on a non-rebreather. Apologies, I have to stop a second. Don't know how to start the actual. I've been having Josh said that it's still trying to spot. He also appreciates. Sorry, when your VP calls, you answer. So, hyperventilation syndrome, right? You're having a patient who's having a panic attack. When they start having that respiratory alkalosis, right? They start to get those carpal pedal spasms. Okay, here's your respiratory alkalosis. So their pH is going up, which means they're becoming more alkalytic here on the bottom because their carbon dioxide is going down. So if you the opposite of that is respiratory acidosis, which is they're not breathing enough. So their carbon dioxide is going up. Okay. And you have your buffer response. Your buffer response brought to you by your kidneys, right? With your bicarb here in the corner, the HCO, that's bicarb. That's a slower response than your respiratory response. Okay, so it's going to take a bit longer for your body to get back to homeostasis if it's trying to fix it bicarb. Okay, just like if your body's trying to fix bicarb or has a bicarb disturbance, immediately it's going to give you a respiratory response, right? So your patients who are in DKA, metabolic acidosis, they're not making enough buffer, not bicarb. So you're going to start breathing faster, okay, to blow off that extra acid, carpal spasms. Okay. Patients also might, yes, HCO3 is bicarb. It's just bicarb. It's not like sodium bicarb. We give sodium bicarb. It's just the bicarbonate ion. So that also the bicarbonate ion will can split up to a H, which is it adds an acid, and the CO3 can so it can either be 1H or it can be water, H2O, depending on how it's split based on what the body needs. So if it needs to be an acid, it'll be an acid. If it needs to be water, it'll be water. Um, so, right, patients can complain of shortness of breath, but will be breathing rapidly. Um, might have chest pain, facial tingling. The carpal spasms are really very significant or noted, well noted. And then you also might have patients who have hyperventilated themselves into temporary blindness. Okay, they to the point where they like literally can't see because they've just skewed their pH so much. The good news is once they get their breathing under control, they're usually much better. Remember we just talked about, might have put a patient on a non-rebreather without anything on, which is not necessarily supported. But we used to say, oh, patient's having a panic attack, give them a paper bag to blow into, with the idea that you're having them re-inhale some of their carbon dioxide that will help moderate their acid-base changes. But basically what you really need to do is calm the patient down. It's psychological first aid. You're going to talk them through it and help them feel better. Not an ALS skill, right? We can do that. We can do that as regular humans with no medical training. It's just knowing and understanding what you're looking at because it can mimic other problems, right? So if you have a patient who's having an anxiety attack, they could be having chest pain. That doesn't mean that you don't do a 3 and a 12. Yeah, you probably know it's a 12 lead, but hey, maybe doing the 3 and the 12 will help calm the patient down because you're telling them, hey, look, you're okay. You've confirmed you're okay. And then they just feel better overall. Lung cancer, this is something you're not going to be, diagnosing in the field, but this is something that you might see a patient having a hard time breathing secondary to a tumor or widespread lung cancer. They might be coughing up blood secondary to a tumor rupture. You might encounter difficulty intubating a patient if the tumor is impeding upon their bronchial and or trachea region, right? If it starts pushing, it might make them, you know, they might have a hard time breathing. You have a patient who's had lung cancer and has had a lung removed, right? I had a little lady, one of the first tubes I remember getting in the field, because we were going 30 miles an hour down Jamaica Avenue while I got it, was a elderly woman who had COPD and lung cancer and had one of her lungs removed. And now she's having a COPD flare up and she couldn't breathe. So when you intubate, you are only expecting to get lung sounds on one side, okay? Sometimes if you intubate and you only get lung sounds on one side, that's normal even if the patient has two lungs because a tumor has encroached the other bronchioles. Okay, so this is like history questions, history taking questions that you're going to need to make sure that you get. It just helps. They might already have, your patient who has had lung cancer might already have a stoma secondary to having cancer. They might also have jaw-related cancers that could change their anatomical structure. So don't smoke is bad for you. Other, basically you're going to make the patient comfortable. You're going to treat their symptoms. If they're wheezing, you're going to give them the bronchodilators and steroids and treat it like an asthma or COPD attack. If they're in pain secondary to, cancer treatment or something to that, like a tumor pressing on a nerve, you might be able to call and request to get pain management. Depending on where you work, you might have to call, or you work in NASA and just give them pain management. Other things that you'll see are going to be related to the chemo and radiation. So radiation can be very painful. It actually can leave burns on the patient's skin. And chemotherapy has a tendency of actually removing calcium from the patient's bloodstream. So they'll potentially show with really interesting cardiac dysrhythmias. I had a woman once who was in a very slow A flutter secondary to chemo and hypocalcemia. Okay, so keep that in mind that if you have a cancer patient, you might see some funky looking rhythms that is due to the chemo. All right, that is the end of respiratory. Um, for the most part, you're not doing anything really wild and out of the ordinary when it comes to treating patients. You're just kind of starting to slot in your new treatments as ALS providers. Okay, so you're slotting in something to the effect of maybe I'm going to give them albuterol. Maybe this patient's having an upper respiratory tract infection and they're wheezing, and I can treat them with bronchodilators and steroids. Okay, maybe I'm going to hydrate them a little bit because I'm anticipating that due to their work of breathing, they might be dehydrated, and if I start thinning out the mucus, it'll be easier for them to get it up. Okay, so it's starting to think a little more critically rather than I put on oxygen and went to the hospital. Okay, you have a few more options in your toolbox to play around with. You just kind of know where they need to fit. Okay. Um, you know, type of respirations. Um, they're good to know. I think the ones that you really should kind of focus on in terms of respirations are your Kussmaul's. Okay, right? Really deep, really fast, right? That patient is most likely diabetic or some sort of acidosis. Most of the time it's diabetic. It's the most common one you're going to see. Okay, and they are trying to blow off carbon dioxide. The thing with that, if you do have to intubate that patient to protect their airway, because most of the time DKA, we're going to go over this in a little bit, but DKA is also seen with concurrent vomiting and potentially GI bleeds, right? You're making stomach acid, your body's trying to get rid of acid, so they're vomiting. If they're on the altered mental status side, you might want to consider tubing this patient. That doesn't mean you breathe for them one breath every 5 to 6 seconds. You might need to hyperventilate this patient because that's a compensatory respiratory pattern. All right, you don't want to be like, all right, cool, I've got control of the airway, and then breathe really slow. You're going to make their acidosis worse. Okay, so just keep that in mind when you have a patient who's doing something like that. The other types of respirations that you should kind of be familiar with are like your Cheyne-Stokes, anything that might indicate that your patient has a head trauma and like a brain bleed, because that's a trauma note, right? That means that your patient needs a different level of attention. Yes, they might be altered mental status, but if they're like, right, and like breathing all sorts of funky, that should kind of direct you to why. Like, what's the root cause of that respiratory pattern? Okay. Not all respiratory is truly respiratory. It can be a metabolic derangement, it can be a head trauma issue, it could be a pain response, right? If somebody's like cracked their freaking leg in half and they're in a lot of pain, you're not going to expect them to be sitting there breathing normally, like, yeah, it hurts a little bit. They're going to be hyperventilating. Okay, that's normal. Like, I wouldn't be upset with somebody who's like sitting there freaking out. Like, that's a normal response. So just keep that in mind when you are assessing your patient. Any other questions? Coffee's cold. All right, I'm gonna apologize in advance. My share button go. My neuro PowerPoints have gone the way of Dodo and have disappeared. So we're gonna use the chapter ones, and I'm just gonna make it as less boring as possible. Um, wow, I just got bored right there. So basically, when you're talking about the nervous system in the ALS realm, not a lot changes from not a lot's going to change from one to the other, right? From BLS. The primary quote unquote neuro emergency that you need to recognize without a doubt is going to be a stroke. Okay. You're going to start picking up on things, right? You're going to have if one patient has a patient has unequal pupils, or if the patient's starting to have a sudden onset of slurred speech. I went on vacation and after I destroyed my own ankle, day one, day two, we actually were sitting out on the lawn, and we stayed at a B&B because we're old on the inside. And the innkeeper came like hustling across the lawn, and she's like, "Oh, we have an emergency." And I'm like, "Well, what's going on?" And she's like, "Well, unless are you guys like EMS or something?" We're like, "Yes, yes, we are. How can we help?" "Oh, the gentleman in room two is having a stroke." Or he was having a stroke, is having an emergency. He's shaking. We don't know what's going on. Okay. So we hustle over there and we're like, "Hello, sir, what is going on?" And he's like, I'm like, "Oh, that's a stroke." Like, his wife is saying he was completely fine. He had a stroke about 7 years prior. Like, he ate today, he vomited last night, wasn't feeling well. Today they went out, they went out and about, they spent the day out, and then they got back and he just started kind of shaking. And then he started getting weak and he's like not making any sense. Aphasia. Aphasia is a really good sign, okay, of something not going on correctly in the brain. So we got EMS, the people with an ambulance. We got the real EMS there, and we got him over to the hospital. And apparently, he also had a concurrent UTI. Just not a good vacation for him. So basically, you just need to make sure that you are recognizing the signs and symptoms of a stroke. Okay, because remember, time is brain. But going back to these really horrible slides, so you have your central nervous system and your peripheral nervous system. Uh, Basically, this is making sure that everything is going the way it needs to. 43 pairs of nerves come from the central nervous system to make the peripheral nervous system. You have 12 pairs of cranial nerves. Cranial nerve number 1 is your sense of smell, which I no longer have. During a trauma assessment, they will give you 10, they will assess 2 through 12. The ones you should really 100% know are your optic nerve, your number 7, which is also usually affected, called Bell's palsy, is cranial nerve number 7, is an irritation of cranial nerve number 7. Your vagus nerve number 10, right, your mouth to your ass. If you overstimulate your vagus nerve, these are your little old people who go and have a constipated bowel movement and die on the toilet because they vagal themselves out. If you overstimulate that nerve, it will bottom out your blood pressure and your pulse rate. And some older people aren't able to compensate during that experience and pass away. Here you go. Boring pictures. All right. We're not going to go hardcore into this. Your neuron, you have your neuron. Um, you should know the 3 parts of the neuron, right? So you have the nucleus in the middle, and then you have dendrites on one side and an axon on the other. Axons tend to be longer than dendrites, but it's also it depends on which kind of nerve it is. Um, and you're never going to be going and dissecting a patient to find out what their nerves are looking like. So don't worry too much about it. But understand that the axons of one nerve cell interact with the dendrites of another nerve cell, and they communicate. Okay, so you have this neurojunction, right, where you have axon, white background, you have axon fingers, dendrite fingers, and then you have all the chemicals transmissions in between. Okay, and that's where chemicals sort of like your pesticide overdoses or your weapons of mass destruction, that's where they affect the patient, is in those junctions, okay? Most of the time, acetylcholine is your main neurotransmitter. Um, got gray matter, right? If you think of the brain, you got gray matter and white matter. Most of the time that gray matter, or like what you're seeing in terms of a brain and all that goo, is fat. Okay, fat serves as an insulator for your nerves. So this is why patients who have diseases like multiple sclerosis have a hard time with functioning, because the disease destroys the myelin sheath, that insulation. That insulation helps the nerve transmissions travel faster. So imagine using an extension cord where that orange outlining part is gone. You might get shocked, right? You wouldn't use that cord because it's no good. So imagine that cord is your nerve and the orange is the myelin sheath. Once you have a disease process that starts to break that down, your transmissions don't travel quite as well as they did before. No one cares. You have sensory and motor neurons, okay, right? If you have a sensory nerve, it transmits senses, right? Your touch, temperature. Motor neurons are the ones that innervate muscles. Collectively, when they work together, they help produce reflexes. So if you touch something hot, it doesn't have to go all the way back to your brain for your brain to go, oh, that's hot, don't touch that, and then go back down to pull your hand away. There are some certain level of basic functions that your nerves can be like, oh, we got this, bro, no problem. I hate this slide. Don't care. Nerves work very similarly to how the electric in your heart works. Nerves use sodium, okay? Sodium is extremely important in terms of making things go from one to the other. Um, Same concept, right? Same concept of moving electric in the heart. It's electric in a nerve, okay? So they need that electron change in order to move um, messages along. Synapses, we talked about that. That's where the axons and the dendrites, there you go. Their axons and your dendrites start to communicate through neurochemicals like acetylcholine. Talked about that. We're going to try to narrow this down to the important stuff. So when someone whacks you in the knee, your brain doesn't need to be involved. So blood supply to the head. You have two internal carotid arteries anteriorly and two posteriorly. Okay, there's carotid arteries and cerebral arteries are in the back. At the bottom of the brain, there's my favorite piece of anatomy, which is called the circle of Willis, because in my head, Bruce Willis is protecting your brain. So it's this sort of like in the heart when you have that collateral circulation. The same sort of thing happens in the brain, where you have your anterior and your posterior arteries could connect into this ring to help produce or help make sure that your brain's getting adequate blood supply. So this is why we've just transitioned into the SLAM score, because SLAMs is very sensitive for large vessel occlusions. So if one of your carotid arteries or one of your cerebral arteries becomes blocked, you will have a slightly different presentation than if you're having a smaller intercranial or intracerebral occlusion. Okay, so the SLAMs is more specific for a larger vessel being occluded. Doop. All right, so you have a number of ventricles in your brain, right? There's just like these open spaces where cerebral spinal fluid is kind of collects, because your brain is constantly being bathed in cerebral spinal fluid. The problem is when some sort of blood or infectious material gets into the cerebral spinal fluid. I want to say there's about, no, I don't have a good number. I don't remember the number. There's a certain milliliter amount of cerebral spinal fluid that you have at any given time. And your body's constantly like moving it through the system, cleaning it out. It goes out and, you know, is constantly new and clean and filtered. But when you have an infectious process in there, like meningitis, you have meningitis, or you have a brain bleed, okay, you're increasing the amount of fluid in that space, and your brain can't deal with it. So you have a specific amount of space inside your cranial vault, and it's pretty unequally combined. You have the mass of your brain, blood, and cerebral spinal fluid. So if you start having more blood in there because there's a brain bleed, it'll reduce the amount of cerebral spinal fluid, but it'll also try to reduce the amount of brain and therefore push it out of the cranial vault through the I can't say that word. The hole at the bottom of your skull. It gets stuck in my mouth. Um,
Raymond
so
Magnum.
thank you. I literally can't say it. It just gets stuck right about the lips. Um, so it gets right then. That's one of your signs of herniation or herniation. Um, you should have a general idea what each part of the brain does. So you have your brainstem, which is the most important part. This is your reptilian brain. Okay, this is the part of your brain that controls all of your base functions of life. Okay, respirations, heart rate, digestion, stuff like that. You literally could be born with only a brainstem and would be able to survive. You wouldn't be much of a human because you are missing all of the other parts that give you things like a personality and, cognition, but you would be a living creature. Oh, it's so cold. Hold on. That was depressing. So, and this is why some people, when they decide that they're going to blow their brains out, are unsuccessful because then they go straight up. All they do is take out their eyes and their frontal lobe, and your frontal lobe gives you your personality. Okay, that's your cerebrum. Your cerebrum is down here on the bottom, is responsible for things like memories and learning, personality, and your sense of time, um, sense of proprioception, which is your sense of your body and space. So that's what your cerebrum does. It gives you more of that like human functionality. And then you have your cerebellum and your diencephalon, which kind of hang out together, which is your hypothalamus, your thalamus, more functions of keeping your body alive. So it's going to do all of the other functions, such as like your hypothalamus and thalamus secrete hormones. Um, Cerebrum might help. It helps, I believe, with your fine motor skills. Okay, so a lot of different things, but you should have a general idea of what does what. Um, Medulla oblongata, the water boy. Um, so basically, our neurological emergencies, not a lot that we can potentially do. A lot of what we do is keeping it from getting worse. Okay. And we'll talk about that in a little bit. So normal cerebral perfusion pressure is between 60 and 80. You're never going to measure that in the field unless you're working as a critical care medic and you've picked someone up from the hospital who has a burr hole in their head and a little measuring stick inside. But you need to understand that, again, there's only so much space inside your head. Okay. So if your perfusion pressure decreases, your brain starts the vessels that just supply blood to your brain start to dilate because it's assuming that your brain isn't getting enough blood and oxygen. And this is one of the essential issues when it comes to brain bleeds. Right? All right, so here's your skull inside your head. Here's your brain. Everything else in this space on here. Brain. All the space around the brain is your blood vessels, is your cerebrospinal fluid, stuff that's kind of just helping. So, if all of a sudden you sprout a bleed, it's taking up space where your brain and your cerebral spinal fluid should be. Ugh. The problem is where else is it going to go? It can't go anywhere. Okay. So your brain or your brain is going, I'm not getting enough blood. I'm not getting enough oxygen. This is a problem. Increase my blood pressure so that I can get more blood to my brain, right? Because your body is very, very good at prioritizing your brain, because without the brain, you are no longer a body. The problem is, as you're increasing the blood pressure, you're also increasing all of the pressure inside the brain, which means that now there's less space for the brain itself. So as you're increasing the pressure, do blue, right? So now you have, oh, for the love of God. So as you're increasing the pressure, because you have blood that's not supposed to be there, your standard amount of cerebrospinal fluid, now you're like increasing the amount of pressure in there due to the blood pressure. The brain's like, oh shit, there's no space for me. And it goes out no, it goes out through the skull and starts compressing on the um the blood pressure goes up, the brain goes out, and it starts to compress on the brainstem, right? The brainstem is right there in the magnum. The FM, we're going to call it the FM right now. So as it starts to put pressure on the brainstem, the heart rate goes down. And as the heart rate goes down, and the more pressure on the brainstem increases, the respirations get funny. Right? That's your Cushing's triad. Right? That's a sign of herniation. It's usually a late sign. So if you have someone who has fallen and hit their head, you have to understand that what happens is the body is doing a really good job of trying to maintain your normal cerebrospinal pressure or cerebral perfusion pressure. Okay? And by increasing the blood pressure, it thinks it's helping itself. But as it increases the blood pressure more, there's even less oxygen and blood getting to the brain because there's no space in there. So it increases the blood pressure more and less blood gets to the brain. And it increases it more and even less gets to the brain. The heart rate starts to go down, the respiration get weird, and your patient's not doing well. Okay? It's a vicious cycle. Um, um, and here is the vicious doodle in squares. Just once your cerebral perfusion pressure starts to drop, the blood flow to the brain starts to drop, and the brain starts to die. This is when you have patients who start having what's called anoxic brain injuries because they're not getting enough oxygen. And as they start to have anoxic brain injury or problems without enough oxygen, they start to have edema. Edema and the swelling makes everything worse, and then the patient's outcome deteriorates and deteriorates. So basically, you want to identify a potential neuro emergency right away. So things like Cushing's triad, you should be kind of able to pick up on quickly. Things like a stroke, you should be able to pick up on quickly. Sometimes a stroke might be subtle, especially a brain bleed in the elderly, right? So we talked about that head, right? Oh, I finally figured out the doodle function. So you have the brain, but as you get older, your brain gets smaller and you have more free space in here. Okay, it's a normal part of aging. So if you do have someone who has a brain bleed building, but they're older, they have more space before it starts to actually affect the brain, before you actually start to see signs and symptoms of a brain bleed, like Cushing's triad or altered mental status. So that's why you want to make sure you're getting a good history. Same thing with young children, right? Very young children, when they still have the fontanelles open, there's space for that pressure to go because the skull is not completely fused. So you want to make sure that you're keeping an eye on that. Another problem that's really significant with patients with brain bleeds, you want to make sure that their airway is patent, okay? They will vomit. Brain bleeds tend to vomit. which means that you need to make sure that if they're starting to get a little squirrely, right, they're not looking as alert and as able to maintain their airway as possible, that maybe you are a little more aggressive with the intubation. Okay, maybe you call and get the etominate to put them down so that you can protect their airway. Because once they start to suck vomitus into their lungs, they're going to have a really poor prognosis. I don't know what the X is. X, the A, B, C, D, E's. Um, talked about most of this. So again, respiratory rate, right? We talked about this a little bit, right? In talking about metabolic acidosis. If you have a patient who's breathing more rapidly and that you're suspecting that it has a brain bleed going on, you don't necessarily want to completely override their respiratory drive if you intubate them. Are going to make sure that their body's doing what it needs to do to kind of protect the brain. So don't totally override it. You can breathe with them. You can maybe breathe a little bit faster on the faster side. Okay, you're not going to be doing it one breath every second, but maybe a little bit faster than 5 to 6. You're going to keep your end tidal in a certain range. If protocols, so your normal range for end tidal is 35 to 45. You suspect the patient has a brain, drops it to 30. Okay, if you keep them 40, you're good. You're satisfying both protocols. So if you're even unsure one way or the other, the patient should be okay. So, vital signs, respiratory patterns. Okay, history, especially a good history of the event leading up to. Things that you see patients complaining of, like thunderclap headaches. Okay, sudden onset of really severe, awful headache, and then they become unresponsive. That's usually a subarachnoid bleed. Okay, patients who have fallen and hit their head. A lot of new trauma protocols, or any patient over the age of 65 with or without blood thinners is considered a trauma protocol if they've hit their head. So, keep that in mind. We're lowering the threshold, and the patient could be completely awake, alert, looking at you, no problem. They look like they're okay. They get to the hospital and the first scan's clean. A couple hours later, they're going to go, they're sitting in the emergency room and they start to get a little altered, and then the bleed will pop up. Any part right here is kind of any sudden drop in the Glasgow Coma Scale is bad, especially if it's 2 or more points. Okay, so if you start off patients looking at you and they're like 15, and then they're like, all of a sudden they start getting confused, drop down, you're like 13, you're like, oh, that's not good, right? That's usually indicative of a significant neurological issue. Yeah, I know. I don't like adding X for exsanguinated bleeding. It's covered in C. I don't see why we need it to. Posturing that we need to do. We need to know. You have decorticate. The patient is reaching into their core. Okay. Usually it's a flexion of the elbows and extension of the legs. You should know those terms because they like to throw those on there because they're the medical terms. Okay, so you're right. You think you go to the gym, you're flexing, right? You're making the muscle. You're flexing. Okay, so you're flexing into the core with your arms and your legs are extending. That's called decorticate posturing. Not good. Okay, but what's worse is the cerebit, right? The patient's extending their arms, extending their legs, and letting go of life. Okay, that is a significantly that's worse than decorticate. Okay, other things that you might see, a patient might be seizing. Okay, patient with no other neurological history, hit their head, brain bleed, and they start seizing. That's significant. That's never good. Pupillary reflexes. The human brain does this really cool thing that if you have a brain bleed and you're altered level of consciousness, you will actually look at the bleed. So say for example I have a brain bleed up here, if my eyes will just automatically start looking up at it. it's caused by the pressure on the optic nerve and the nerves that control the muscles in the eyes. So as it pushes down, the eye will look up at where the bleed is coming from. Really cool, kind of scary. Um, when you see in real life.
What happens if where you know how like you can be bleeding in like the middle of your brain where like the brain separates or pushes together? I don't remember what that's called.
The
Um,
foot crack. Mm-hmm.
but what happens then? Like, will you like just like look
Straight up.
like cross-eyed kind of thing, or like
You look straight up.
okay,
So you have a ventricle right there in the center of your brain that can fill with blood. That's that's a done deal. Like you're donezo if the ventricle starts to fill up, unless they can get in there quickly and remove the blood from that space. It's
but
not a
doesn't
good
the
outcome.
brain actually like close together or push apart? I forget.
So your brain. Have
Are
we
you,
talked about the ventricles?
are you talking about the corpus callosum that divides the left hemisphere and the right hemisphere?
No, he's talking about the ventricles. So you have that you have the space down the middle, right? It's called your midline.
Oh yeah, midline shift.
Midline. Okay. So if you have a bleed, say it's here. So say this is your bleed. It can get to the point where it will actually start to push the ventricles. And because the ventricles are full of cerebrospinal fluid, you'll see them get smaller like this. You'll see that, especially on the CT scan, you'll see it kind of squish. Okay, and then this will just become brain here. The problem is also when you have the brain butterfly. If you get blood inside the ventricle here, that's no good, no bueno. Okay, that ends very poorly for patients. Yes, that's it's called the midline shift. James, what you're talking about the corpus
Thank you.
callosum, yeah, it comes across and it connects your left brain and your right brain. You back in the day, they were doing these surgeries where they would actually patients who had really bad seizures, they would surgically cut the corpus callosum um, to help prevent the seizure activity from going from one side to the brain to the other. So imagine like in the heart, right, you have your SA node goes to the AV node. Imagine cutting it at the AV node. So your electrical impulse never gets from the top part of the heart to the bottom part of the heart. Okay. And it would prevent seizure from spreading all the way across the brain. However, the problem with that, you can live like that, but patients were having other like kind of weird side effects. It was actually kind of affecting their moral compass, which was kind of interesting. Um, there were some really interesting studies on it. They actually stopped doing that surgery a bunch of years ago. I forgot about how many, but they stopped doing it because it was like kind of ethically curious. One thing that when we talk about other than the gaze, okay, the gaze, you will 100% like you walk in and say patient's got a leftward gaze, they will know what you mean. Like that means that the patient's looking up to the left. It's a good possibility to have a brain up in the left. Another thing that you might see in patients, especially if they've had a traumatic head injury, is called nystagmus. So their pupils will bounce back and forth like really quick. Um, it is sometimes you have patients who have that normally, and they'll know like their pupils just bounce. They can see fine, but if it's secondary to a head injury, it's usually a good sign of this level of severity. Coma, right? This is your GCS of 3. It could be caused by all sorts of different issues, structural lesions, right? Like a brain tumor. It could be toxic metabolic, right? So your patient might have DKA, your patient might have narcotics, okay? One thing to remember, so if you have a patient who is completely unresponsive, right, and they're not doing a good job of responding to you, and you give them Narcan, right, and they still have those pinpoint pupils, it's a possibility that they have what's called a pons bleed, okay? This is low in the brainstem, and it usually presents with pinpoint pupils and is very commonly mistaken for a narcotics overdose. Narcan in this situation will not do anything to hurt the patient, but it will help you rule out the diagnosis. That doesn't necessarily mean that your patient didn't also just take a buttload of narcotics and that they need more Narcan. Um, but this is the patient who you're like, really didn't think that grandma over here was, popping perks and living it up. Um, this is you should have a level of suspicion if Narcan doesn't work. Oops. If Narcan doesn't work for your patient with pinballs. Go to your textbook for your 6 general causes of coma, right? This is kind of like you're still doing H's and T's. Or here are your AEIOU tips because we like to acronym absolutely everything. Um, just these are things that you probably are already thinking, okay? Just add this. Here in uremia, I'm going to add one. It's ammonia. Okay. It presents also very similarly. It's when the patient has liver problems. Okay. So they might also look a little yellow. They might not, though. If they start to go into liver failure, their body will build up ammonia and will potentially present with stroke-like symptoms as well. I had one woman who had a very high ammonia, and the first time we had her, she presented altered, called in as a stroke note. Second time, died from a stroke. Story. Um,
If you have a pons bleed and like those constricted pupils, is that likely to be symptomatic like from onset kind of thing, or is that like a delayed onset where you could be sitting alert and oriented GCS baseline like 15, 14, something like that, and be asymptomatic until the point where the bleed
it gets
spreads
big.
further?
I'm not sure. So, basically, the pons is a very small area. So once you start having a bleed in that area, it's significant. Um, I don't know. I don't have good numbers on at what point like the pinpoint pupils start, or like most of the time, I believe pons bleed patients are kind of just unresponsive or like deteriorate very quickly. I can look into that more though. I have to give you an update on that one. Toxic or structural versus toxic, right? So if you have a very unilateral presentation, it's more likely to be structural versus toxic or metabolic, with the exception, obviously, of the pons bleed, which will most of the time affect both pupils. Um, this also, you see, this is also when it comes to the central nervous system versus the peripheral nervous system or your Bell's palsy, right? You'll have one side of the face which is unilateral, but there will be other signs and symptoms that, like the patient will have potentially clear speech and they'll only have facial drooping. You ask them to raise their eyebrows in stroke. The eyebrows will raise unequally. In Bell's palsy, it's a different nerve, so they'll raise normally. So there's ways you can kind of rule out. Most of the time, Bell's palsy is caused by an ear infection that kind of goes and gets into the so just things to kind of keep in mind. Time is brain. Don't futz around on scene. Period. End of story. It's just because you are ALS does not sit there and get it. IV and do this and do that. Sure, do a 3, do a 12, just to make sure it's not cardiac in nature as well, because sometimes you can have cardiac issues that mimic a stroke. Do a blood sugar stick, and then go. Like they're gonna put an IV in when they get there. If they're going to give that patient TPA, then they don't want you to miss, right? Because then they can't. If you just fill this patient full of pinprick holes and they give them TPA, they're going to start bleeding from all those spots. So unless you know for sure you're going to get it, let the hospital do it. Just go, okay? You want to do it while you're en route, sure, but again, remember your safety is important. Talked about that. There's a bunch of different things, right? Stroke. A lot of people are at risk for stroke. Family history. A lot of sitting. Patients who have DVTs. Okay, AFib, the huge stroke risk factor. Um, So as much as the Circle of Willis does a good job to help provide collateral circulation, deep into the brain, it's one way in, one way out kind of thing. So if you have an occlusion or a hemorrhage, there's just not getting blood to that area of the brain. So if you guys remember brain again, so if you have like a spot right here, okay, that's your occlusion, and that part supplies this whole area. The problem with an occlusion is this dead area right here now is at high risk for hemorrhage. So you can have a patient who has had an occlusive stroke, it wasn't 100% treated, and then they end up having a massive hemorrhage around it because this dead tissue isn't handling the dying part peacefully. Okay, it becomes, well, the vessels over here become weaker. So you might have a patient who has a hemorrhagic on occlusive stroke. Okay, this is when you should have a suspicion of someone who's had a stroke, has been discharged, and has symptoms similar, like similar symptoms later. Okay. Most of the time, it is a cerebral ischemic stroke. It can be either a combination of that there's plaque in the brain, similar to how a heart attack happens, or it could be because there was a DVT. Oh, what in devil? What happened? Hi, still with you?
I think that was my fault. My phone's doing some weird shit.
Ah,
I don't know how that happened.
that was weird.
My phone also did the same thing just now.
I think we were just electromagnetic pulsed. All right. So, right, so you have your ischemic stroke. A DVT can break off, AFib clot can get sent to the brain, or you can have a hemorrhagic stroke. Can also happen almost anywhere. It could be traumatic or atraumatic. There's plenty of patients who have little things called like berry aneurysms, right? There's little teeny tiny aneurysms in the brain that just kind of are off to the side. AV malformations, right? So instead of it going from an artery to arterial to capillary bed to a venule to a vein, it just goes artery to vein, and that level of that change in pressure weakens the area of the vasculature. And hypertension. Hypertension is probably the number one reason that people have issues. It's in your textbook. TIAs. TIAs are any change in mental status and or presentation of stroke-like symptoms that resolve within 24 hours. Last question.
Cool. How often do these present as seizures?
It depends. It
Okay.
really depends. It's a combination of what part of the brain's being irritated and how bad the bleed is and how fast the bleed comes on. It's not about a brain, in terms of a brain bleed, it's not about the amount of blood, it's the speed of the blood. Okay, so if people live with very slow trickling brain bleeds for like ever. Okay, you'll have people who you'll be transporting from a doctor's office. They're like, yeah, they have a brain bleed. And they're like, yeah, they've been walking around with this brain bleed for like 3 weeks. But it's a slow trickle of blood. You might not see anything. And then you might have somebody who has the same amount of blood, but it happened within 10 minutes, and their altered mental status is because the brain doesn't have time to adjust. They usually, patients who had significant head trauma or a significant brain bleed, they'll put them on prophylactic Keppra to prevent seizures because they really don't know if they're going to have a seizure or not.
Okay.
Okay. So TIAs, all right, 24 hours. Symptoms resolve within 24 hours. Okay. Always a test question. Identify the stroke, get them to the appropriate hospital. In this region, the majority of hospitals are primary stroke centers, which means they can handle a stroke. Now that we are using SLAMs, you need to take the patient to a comprehensive stroke center. Okay, your comprehensive stroke centers are Jamaica, Brooke, Manhasset, and I'm sure I could pull up a few more if I Googled it because I know like Queens and Nassau. Brooklyn, I believe Lutheran is a comprehensive. Trying to think what other hospitals are. Coney Island will probably start working its way towards being comprehensive because they have and basically if a lot of places that have PCI, right, for heart attacks are comprehensive stroke centers. Oh, but not all of them, because not only do they need the ability to do thrombectomies, they need the appropriate neurosurgeon on staff also. So check your protocols, see where you're going. Here's your 8Ds stroke management, also in your textbook. Check it out. So the SLAMS is your Los Angeles pre-hospital stroke screen, but it adds speech. SLAMS scale. Sorry, this one. Okay, LOL. So it's I forgot off the top of my head. It's very similar to the Cincinnati. It just gives everything points differently. Pick up. Faster. Ooh, faster is a thing too, apparently. Wow, thanks Google, for totally failing me here. All right, SLAMs. So write your speech, facial drift, arm, facial droop, arm droop, motor, and if they can follow, speech. I think I said speech like 3 times now. I might also be having a stroke. So, right, you want to make sure that you're managing all of the things that you would manage in every other patient. Okay, so if your patient's having a stroke and they're vomiting, you might want to consider giving them Zofran. Is that going to hurt them? No. Is it going to potentially protect their airway? Yes, because if they're awake enough to maintain an airway but they're excessively vomiting, you don't want to tube them. Tubing them is going to give them an extra long time in the hospital. But if you can reduce their vomiting, make them more comfortable, because vomiting also increases the pressure in one's head, then hey, you've done something right by the patient. You're just going to use common sense here, okay? Just because the protocol this is potentially labeled one thing or another doesn't necessarily mean that you can't use it in other contexts, okay? Vomiting is vomiting. So in the hospital, either they'll do thrombolytic when where they'll go in and they'll use the TPA clot buster to try to remove the clot, or if it's a large vessel occlusion, they'll go in and they'll roto-rooter it out.
Nicole, I have a question.
Go ahead.
That's the what you just said about like doing something like that's not necessarily in the protocol, but it's like doing right by the patient or whatnot. So yesterday I had a patient who was an APE. I don't know what, but this medic arrived on scene, they gave him CPAP, and they were like, "Oh yeah, but you guys could have done epi. We wouldn't have done it, but you guys could have done it." And we were like, "What are you talking about?" Like, so I was just like, I want to ask Nicole about that because I don't know what these guys are talking about.
Because he didn't recognize it as APE.
Right?
No, he was just I'm going under the impression that that was asthma.
Yeah. He was like, "You guys could have
No.
gave her epi," and I was like, I'm pretty sure we couldn't, but
Pretty sure you would have killed her.
yeah.
Please don't. Public service announcement, please don't give your APE patients epi. It's generally bad. It's generally up there with giving your APE patients like albuterol. You're just going to open up their lungs more because it's a bronchodilator. It's going to increase their heart rate, which means it's going to increase the workload of their heart, which isn't doing a good job anyway. And you're going to just flood them with fluid and make them worse.
Mm.
They need CPAP, period. End of story. Like if you're going to do any sort of medication, it's nitro. Where were
Yeah.
you?
This is in the Bronx. These were Finney medics. So,
Oh, there you go.
yeah.
There you go. There's your answer.
Yeah, we were telling them because we couldn't, like, lung sounds were kind of distant
Mhm.
and whatnot. So we're like, hey, this might be, she had like edema and all that stuff, chest pain, showing some breath since yesterday. We were like, yeah, this is probably AP. And they were like, and then they went for lung sounds. They were like, it sounds clear to us. And we're like, all right, that's
Yeah, because
cool.
they didn't listen. That's why they didn't actually listen. They don't know. That's the problem is a lot of people don't know lung sounds very well.
Yeah.
In general, and across the board, lung sounds are hard, and lung sounds are hard in the back of an ambulance with diesel engine going, or on scene, or somewhere that's not like a perfect clinical environment. And people who probably only bring their stethoscopes in half of the time, they're not going to have good knowledge of lung sounds.
Also, her BP was like 200.
Yep.
So I was like, epi would have been like
A terrible fucking plan.
300. Like, you know what I'm saying? Or whatever.
100%. No, that would have killed her. It would have killed her.
Yeah. All right. Just wanted to ask you about that. But that's what happened yesterday. So.
Well, don't use Epi on those patients. Thank you for being smarter than a medic. A game show. Well, moving on from that sad, depressing fact. So other things that you might have, you will definitely see in the field: seizures. If a patient has a history of seizures and they have what's called a breakthrough seizure, not really a big deal. Okay, sometimes doctors will play with patients' medications to see if they can reduce the amount of medication that the patient needs to function on a daily basis. Sometimes a patient forgets to take their meds. It happens. Okay, the meds ran out, they didn't get to the pharmacy. Shit happens. So they might have what's called a breakthrough seizure. Totally normal. It's usually a brief period of time, and then they, come to. The longer the seizure, the longer the postictal phase. Okay, it's just how it is. Your patient's going to be confused for a little while. So you might show up and the patient's now perfectly fine, doesn't want to go to the hospital. That's okay. You potentially RMA them, but those patients need to also go follow up with their neurologist because bringing them to the ER is not going to fix their problem. Because doctors go, you had a seizure. And they're like, yeah, I know. I've been having seizures for like the last 20 years. I forgot to take my meds on time. And I had a seizure. And they're like, all right, cool, take your meds and send them home. Meanwhile, like if their neurologist is futzing with their medication because, maybe you have a woman who has seizures and she's trying to get pregnant. Some of the seizure medications might not be compatible with being pregnant. So if they try to switch her meds, she might have a breakthrough seizure, which means that the ER is not going to do anything. Her neurologist is. So it's like, diabetics who take a little bit too much um, of their insulin, forget to eat, and you feed them and they're fine. Kind of the same concept with seizure patients. However, you can have patients who've never had a seizure before start having seizures. Okay, most commonly it's going to be secondary to something like a brain tumor or an infection or a really high fever, especially in kids, or a stroke. Okay, so any of these things can cause seizures, sort of like the H's and T's that you see when we talk about heart and cardiac arrest. Very similar concept. So you just
That
want to,
happened to me on a call last week.
yeah.
Did a patient full seizure, bit his tongue, urinated, postictal, stayed postictal for about 15 minutes until we got to the hospital, continued to stay postictal. He had a bleed. No history of seizures, like confirmed by family.
So that's what's really important when you get the history from the family, if they have, and you can also check the medication. So phenobarbital is a seizure med. Heparin is a very popular seizure med. A couple other ones you might see here and there might be used like off-label. I think Imitrex is one. It's a migraine medication that can also be used, I believe, off-label for seizures, or a combination of stuff. So if you have a patient who you can't necessarily get a history from, check their meds. If they don't have any seizure medications, it might be a new onset, and you should be more concerned. When it comes to seizures, though, young children up to approximately the age of 5 can have seizures just secondary to a fever. Febrile seizures. I'm sure you've all dealt with them at one point or another. Similarly to a brain bleed, it's not about having a fever, it's about how fast the fever rises. So mom and dad could be doing absolutely everything right. They're giving them Tylenol and every 4 and ibuprofen every 6, and they're keeping a close eye and they're trying to keep their baby cool. But that baby has, or that young child has, a very underdeveloped hypothalamus, which is where your brain controls temperature. So all of a sudden, the body's going to go, oh, guess what, guys? 104, and just ramp up a fever, and that's going to cause a febrile seizure. Much more stressful for family, the parents, than the kid. It's usually a very short-lasting seizure, okay? Babe comes right out of it, has almost no postictal phase because they're like, what just happened, all right? Because the brain was like, oh my God, it's so hot, and that's the end of it. Once it realizes that the temperature's changed, it gets its shit together, essentially. Things that you need to kind of keep a look at, especially with pediatrics, is when it comes to seizures or new onset or undiagnosed seizures, when the kid does that, right? They're talking, they're acting normal, all of a sudden they're like, a lot of the times kids who have focal seizures, like this that we're talking about right here, will look like they're just not paying attention in school, okay? They'll just all of a sudden, like, they look like they're daydreaming, okay? This is why sometimes like more minor seizures aren't diagnosed until a child is much older. You also might have a patient who does lip smacking.
Can administration of narcotics cause focal seizures, or is that rare?
Honestly, don't know. That's a good question. I really don't know.
Because I've seen that once. Someone was giving morphine, and the woman was like clearly having a focal seizure afterwards. Like you could, when you looked at her eyes, like she was having a focal seizure, and we didn't know if it was more attributed to the medication administration or from her level of pain and everything else.
It was most likely, I'm going to say, probably due to her stress.
Yeah.
So just like, asthma and all this other stuff, all those things are stress related, right? So like if you have a significant level of stress, your body's like, can't deal, and whatever the dysfunction is going to be what's kind of bubbles to the top. So seizures, asthma.
Right. It might have been building up prior to the medication administration, but then
Yes.
gotcha.
So
So I have a question.
Good.
So the febrile seizure, since it's just like the rise of the temperature moving too fast, you just for the child, you just try to lower the temperature of the child, right? And it should just be fine, right?
But you don't want to lower it too fast. So some ice packs in the axillary behind the neck, but you don't want to like really get them too cold because then you'll cause them like a lot of shivering, and then you'll kind of shift it the other way too much and they'll get hypothermic. So you don't want to bundle them up. You want to let the heat come off of them so that they can kind of maintain. But yes, exactly. You want to make sure that they're not getting that you're not holding that fever in.
Okay.
Motor onset, right? That's like it can be anywhere from like one limb is doing its own thing to a full-blown tonic-clonic and or generalized onset seizure. Okay, so when the whole brain is involved. I like to describe seizures as like the Control-Alt-Delete for your brain. Something's going wrong in the electrical system. It's having a little bit of a short circuit, and the brain just does a quick turn off and turn back on. To deal with it. Hold on 1 second. To call me when I'm in class. All right. there is a there is a difference between syncope and seizure. Okay.
Well, quick question.
Go ahead.
Have you ever had somebody go from like a localized seizure, like in like an arm or something, to like a full blown like tonic-clonic seizure?
Yeah, it can happen.
Do you like treat them? I mean, like you don't treat them until they have the full blown tonic-clonic, right?
Yes. Most of the time, the focal seizures where it's like a small, like one arm motor or, like a little absence or something like that, they usually resolve relatively quickly. It's when it becomes a full tonic-clonic and it's affecting their breathing, right? Because the whole brain is involved and now they're not breathing properly, that's when you really need to intervene because you want to make sure you're maintaining your airway, breathing, and circulation. So yes, very good. Yes, so the benzo does stop. So when you give benzodiazepines, it affects what's called the GABA receptors, right? And the GABA receptors help calm the brain down. These are what promotes sleep, which is what helps with the sedative aspect of like benzos, right? So if you're trying to calm somebody down, you're essentially making them sleepy. You're stimulating these receptors, and asking them to be like, hey guys, let's all just chill, okay? So when you start to chill, the overall chill vibe that benzos give you, it helps reduce the seizure activity. So determining a syncope versus seizure can be challenging at times. A lot of the times when you have syncope versus seizure, you're kind of at the point where the patient has lost consciousness completely, so you're assuming that the seizure is a generalized. Most of the time, syncope has cardiac issues, right? Because there's a cardiac issue or a lack of blood flow getting to the brain, where a seizure is neuro. When you're going to status epilepticus, it's usually defined as a seizure lasting more than, they've reduced it now to 5 minutes, or multiple seizures, more than one or two seizures occurring without a lucid period in between. When you're actually out there on the field, if they're saying, oh, he's been seizing for like 2 minutes, that, people's sense of time gets warped when there's an emergency. So you don't necessarily have to take their word for it. I know that the protocol says, oh, you're only treating it when it's a stat ep, but how long do you let somebody see and not effectively breathe before you decide to treat it? Because you're not going to ventilate someone who's actively seizing. It's not going to happen. You're not going to be able to get a good enough control of their head to actively ventilate them. So you can have a lower threshold for what stat ep is when you're actually in the field treating it. But you should also kind of know, you'll start to pick up on it, pseudo seizures versus actual seizures. So position, the most important thing that you want to do when you're positioning a patient who is having a seizure is to make sure that there's nothing around them that they can hurt themselves on. Most of the time, syncope starts when the patient is standing. I've seen patients syncopize while sitting, so it's not 100% of the time. Whereas seizures, again, anywhere. Sometimes patients with seizures will have what's called an aura. They'll smell a certain smell that might not be there. They'll see lights in front of their eyes. They'll hear a sound and they know they're going to seize. Whereas patients who are having syncopal episodes might feel a little dizzy, lightheaded. Once you get the patient, a patient who's syncopized flat, usually they'll come back. Your muscle reactions are more commonly seen here. And patients will have more likely to have tachycardia with seizures because if you think about it, all that tonic-clonic action is sort of like a workout. So they're going to have that kind of level of response.
Nicole, I just have a quick question. So yesterday, one of the calls I had was a seizure, and she started seizing in front of us on the bus on the way to the hospital. But about a minute before she started seizing, she became very diaphoretic. Is that pretty common?
That's probably her warning sign.
Okay, thank you.
Patients who have seizures, they can have an array of different things. Like you can have somebody who's like, I taste metal, or I'm seeing spots, or I smell burnt toast, or something like that. Like sometimes the brain will give them like a little bit of like a, hey guys, you're gonna do that. I guess hers is probably just diaphoretic because her body's starting to prepare to overreact essentially. Um, always encourage your patients to go to the ER. You're gonna have patients who've had history of seizure for a long period of time are going to be resistant to it. Yep, they did change it. Any more than 5 minutes is considered stat ep. Remember, if you are seizing, you are not breathing. You want to make sure that you are getting oxygen on your patient and that you are stopping the seizure as quickly as possible. Somehow managed to put the slides out of order. So, stat ep, protect the airway, medication, prepare yourself for more severe issues. Now, headaches. If your patient is complaining of anything kind of more significant when it comes to headaches, or it's like a thunderclap headache, or if it's a something where they're having serious mental or altered mental status, that should kind of drive you more towards the brain bleed side. But there's plenty of patients who have headaches on the norm. However, there are patients who have people in general who have never had a headache. I don't know who these people are, but they're lucky. But all of a sudden, if you have a patient who is saying, I'm having a headache, and they've never ever experienced a headache in their life before, that's a concern. Okay, that needs to go to the ER, period, end of story. Now, migraines are different than headaches. Migraines are severe, they're incapacitating, and they have other symptoms usually associated with them. It's thought that migraines are caused by serotonin influxes, and it's usually headaches are caused by vessel constriction, whereas a migraine is caused by vessel dilation. Okay. You patients will have a photosensitivity, they will have nausea, vomiting. The problem with migraines is the nausea and vomiting component makes it really hard for when they take medication to help reduce it, for that medication to actually work, because they're not digesting well. Okay, so it's going to extend the period of time that it's going to take for that medication to start working. Caffeine is considered helpful in a migraine situation because it does reconstrict those blood vessels in the brain. So migraines can also mimic a stroke, okay, if they are really bad. And if you are not sure, take them to the hospital, okay? If the patient's like, oh no, it's a migraine, this is how my migraines always like look, that's one thing, okay? But at the same time, you need to make sure that you're doing the right thing by the sinus headaches, right? We're all familiar. They might be up here, they might be down here. You want to just, it feels like a pressure on the face. Everyone's probably had a sinus headache at one point or another in their life. People who know what their triggers are will know why they have a headache. Like I drink red wine and I get a headache. Okay, did you drink red wine? Yes. Now you have a headache. Okie dokie. It can be a sign of an aneurysm, but again, it's a wide range of things that it could. Now in terms of weakness and fatigue, okay, there are a number of things that could cause weakness and fatigue. It could absolutely run the gamut. Usually this is potentially one of those vague symptoms that can be a part of almost every system. Okay, you might have weakness and fatigue because you have Lyme disease. You might have weakness and fatigue because you're anemic. So you have contagious diseases, immunological, hematological. You could have low blood pressure. You could be having a stroke. It could be almost anything. Okay, so this is one of those things that you will probably need to evaluate on a deeper level. And that means doing a full workup, doing a finger stick, doing a 12 lead, doing, giving the patient maybe a bolus of fluids and seeing what's going on. And yes, there's going to be things that you're not going to be able to treat that is causing weakness and fatigue. but this is when you need to make sure that you're getting a very good history for that patient. All right, so infections in the central nervous system can come out from all sorts of other areas. Meningitis and encephalitis. Meningitis, right, is the inflammation of the membranes around the brain and spinal cord. You see this commonly in group settings, okay, because it spreads very easily. Most of the time, viral meningitis is more common, but bacterial is deadly. Okay, bacterial meningitis is extremely serious and deadly. Viral meningitis will resolve on its own. Most of the time, right, your hallmark symptoms are headache, fever, and nuchal rigidity. Nuchal rigidity being neck stiffness. The patient will be unable to bring their chin to their chest comfortably. That's one of the ways you can look. There's 2 other tests for meningitis that are in your textbook that you might want to just review really quick. It involves knee flexion, pops up every once in a while. Encephalitis is inflammation of the brain, and not only can it be caused by viral or bacterial infections, but it also could be caused by like toxins, like alcohol. You can have alcoholic encephalitis, okay? Basically, the patient can have flu-like symptoms and they just don't feel well. Brain abscess, sort of like a tumor, but it's infectious materials, okay? Kind of non-specific. Again, it might present like a brain bleed, okay? Like a slow developing brain bleed. A lot of the times when you're assessing a patient for neuro symptoms, you want to ask questions about, have you had any recent dental work, okay? Or maybe a recent ear infection or sinus infection. The bones of your cranial vault in that area are very thin in the sinuses and the ears, so it's easier for bacteria to get in there. When it comes to dental work, there's a lot of bacteria that live in your mouth, and if they're like deep cleaning in your gums, your heart and your brain are 2 of the areas that the bacteria will get dislodged to if they're doing dental work. It gets right into your bloodstream and goes right to those 2 places. So if someone has had this is why they usually treat people prophylactically with antibiotics before they have dental work. So you want to just, get a good history and make sure that that's not something that might be there. Brain tumors, whole variety of different brain tumors that are a possibility for patients to develop. Glioblastomas are the most inoperable and fast growing. But again, you won't be diagnosing this in the field. You are more likely going to be dealing with a patient who's having a therapy or radiation side effect, is just generally not feeling well. I had a gentleman once who had a brain tumor and was seizing for a solid 20 minutes before his family called 911, and then we could not control we gave him 10 of midazolam and then 20 of diazepam when we still carried it, and he seized right through it because it wasn't a seizure, it was his brain tumor. So those are, you can expect all sorts of different varieties of things to happen with brain tumors. It's going to depend on where the tumor is located. Like, not important. Again, there's a lot of different things that the tumor, depending on the location, can create issues there. Again, a lot of these talked about already. Emotional support. Okay. So we have dementia. Okay, dementia or Alzheimer's is different ways that one can lose their cognition and memory. They're relatively slow, progressive losses of awareness of time and place and person. As the disease progresses, the person is less and less able to do things like the activities of daily living and will require more care. These patients obviously have a lot of difficult time with things. Um, it could be caused by strokes or genetics, Alzheimer's. Um, Usually they'll remember stuff from like early in their childhood, but stuff that happened yesterday is gone because there's no ability for them to make new pathways is lost. The brain starts to shrink, so patients who have dementia and Alzheimer's, if they do happen to fall and hit their heads, one, they won't necessarily remember. Two, they're not going to be reliable historians. And three, it might be an extended period of time before it actually shows signs and symptoms because there's that extra space going on in that head. Um, None of these things have cures. A lot of the times, dementia and delirium are between the two. Delirium is a sudden onset of a mental status change, um, as opposed to dementia, which is progressive. You can have delirium on top of dementia. You might have patients who experience things, what's called sundowning. So they might have a little bit of dementia, right, when they're just a little forgetful here and there. But then you start to have that twilighting phase, right, when the sun starts to set and the dusk sets in, and the patient will start to get very, very confused. Okay, that's why it's called sundowning. You see it in hospitals a lot. You see patients who are long-term dementia care at home have that issue as well. Starts in your book. This is spelt wrong, which makes me sad. It's Huntington disease, with a T, not a D. Huntington disease, if anyone ever watched House, this is what Dr. 13 had. Huntington disease is, again, degeneration of the neurons in the brain. It causes a whole breakdown early on. And unfortunately, the disease is not curable. You have muscular dystrophy, which again, this is like another chronic disease where patients, depending on what kind of muscular dystrophy, will have various effects of how their muscles on their muscles. So you might have patients who have core problems, limb problems. They usually have a shortened lifespan, because the muscles just start breaking down, and that then passes on to their diaphragm, their rib, their intercostal muscles, and their heart. So they're otherwise A-OK and may be cognitively very sharp, but their body is betraying them. Demyelinating or disorders. We talked about this already a little bit. Multiple sclerosis. Okay, so it's considered one of the autoimmune diseases because it can flare up. Okay, so it might attack some nerves here and there, and then the next day you'll be fine, or you'll wake up one day and you're not able to walk because the myelin sheath is being attacked in your legs that day. It starts to scar up the nerves. I knew a girl who was probably about 16 and she had multiple sclerosis, and she had lost all of her central vision because of it. So she needed a magnifying glass to see because her vision was that bad. That's also in your textbook if you'd like to look at a chart. Again, we aren't necessarily treating multiple sclerosis. You're going to be treating, the side problems, right? So they might be, I aspirated, or I have a fever, or my medications are not, again, diarrhea or something for my medications. Okay, you're not the ones diagnosing it. You're managing the patient's other complaint. Yeah. Peripheral neuropathies, right? This is one of those bigger problems that we see when it comes to like diabetics, because they can't feel their feet. They could have a dying necrotic toe and they're super septic and they don't know why because they stubbed their toe 2 weeks ago, it broke, and then died. You can have it, most of the time it's associated with diabetes, right? Because large sugar molecules tend to destroy nerves, but it can be also just kind of idiosyncratic. All of a sudden your nerves are dying. It could be multiple sclerosis. It could be all sorts of other things. May or may not be officially diagnosed. We have Guillain-Barré syndrome. Guillain-Barré is a ascending right? Ascending paralysis. So it starts from the feet, works its way up. All right. You commonly see Guillain-Barré after a severe infection. Also can be caused by a vaccine. If a patient is already kind of prone to an autoimmune disease, it can trigger the Guillain-Barré cascade. If the ascending paralysis stops before the diaphragm, usually not too bad, right? The patient might have weakness in their legs or ongoing weakness in their legs, or you know, or may have a full recovery. They're really not 100% sure what causes it because they think it might be autoimmune, and once you throw the word autoimmune in there, everyone loses their minds and is unable to tell you what's causing it.
Can it be
Okay.
caused? Can it be caused by trauma or like something like struck by lightning? Only because I've seen somebody present similarly to that with a lightning strike, but
So I'm going to
we
say
didn't really.
it could have been the lightning strike could have been the cause of the paralysis, or it could have been that the lightning strike was the body assumed it to be a burn, and then there was an extreme immune response because of the burn that promoted the Guillain-Barré. Not sure.
Okay.
Good question though. Movement disorders, right? Which looking here, and it's looking like we're not even gonna put Parkinson's out there. It is. So you have Parkinson's disease, and then you have Parkinson's syndrome. Parkinson's syndrome is tremors, like just external tremors that never progress anywhere. Think Ozzy Osbourne. Okay. Dystonia is just diffuse muscle changes. Usually it's rigidity. So you might see someone who's got like a severe wrist cramp like this. It's dystonia. They might have wrist braces on to help keep the joints intact. Parkinson's is the loss of dopamine. So on one end of the dopamine scale in the brain, have a loss. Hold on. You have a loss on this side, so you have Parkinson, low dopamine. And
You can actually have, I don't know how much you know about that, but you can have global dystonia. I know this because I have a child with global dystonia. It's kind of I don't really know well, they don't know what causes it. It's a neurologic condition, but I did not know until my child was diagnosed that any kind of change in muscle strength without change in actual muscle structure is completely neurologic, which is just a little interesting fact. If somebody has a severe change in muscle strength or ability to whatever, that's completely neurologic. Even over a long term, he's had it his whole life. So just a little interesting fact. And often is accompanied by chorea, which is these fluid movements that they see with dystonia. So there you go. If you ever see somebody having muscle strength and issues and moving their hands and muscles and fluid movements, also a sign of something neurologic going on.
There you go. Thank you. So you have like this, and going back to dopamine a little bit, you have this kind of continuum of dopamine in the brain. So if you see patients who have very low dopamine, it's usually Parkinson's. On the other side of that continuum is actually very excessive dopamine, which is usually schizophrenia. The dopamine causes that, like the hallucinations and such. Which is why when you have patients who have Parkinson's who are on carbidopa levodopa, I'm going to write that, which is the one of the medications that they give. This medication is able to cross the blood-brain barrier, get into the brain, and then turn into dopamine. So it helps alleviate some of the tremors that they deal with and the fine muscle problems. The bigger problem with carbidopa levodopa is that once it gets in there, it can actually cause severe hallucinations that look, I don't know, like schizophrenia. Carbidopa levodopa is usually saved for when patients are progressing in Parkinson's. But both Parkinson's patients and schizophrenic patients tend to present with a very flat affect. I'm not sure what causes the schizophrenic hallucinations exactly, but I know it's due to high, I don't know if it's like an influx, but it's just overall they have too much dopamine in their brain. But they tend to have a flat affect, right? So if you look at any recent pictures of like Michael J. Fox, and he doesn't look like he's really got like a lot of muscle tone, that's why, because he's lost that, the ability to really control those very small muscles of the face. The things that you also might see patients with Parkinson's, it's called pill rolling. Okay, this is one of the earliest signs of Parkinson's, is they start to do this pill rolling thing where it looks like they're rolling something between their fingers. So just things to keep in mind. And Parkinson's patients tend to shuffle because they lose like that sensation of their feet. So to find the ground, they'll shuffle, which puts them at an increased risk of tripping and falling. Okay, so also stuff to keep in mind for those kinds of patients. This is in adult too. So other than losing the fine muscle motions in Parkinson's, you also end up with very tense muscle. Bell's palsy. Okay, this is really, you're gonna probably see this one at least once or twice. The patient will have stroke-like symptoms, and one side of their face will be drooping, and you'll be like, it's a stroke, and like they have no other symptoms other than the Bell's palsy, and they're kind of young for a stroke. You want to ask them to move their eyebrows. Okay. Trigeminal neuralgia is usually, it's like a facial pain. ALS. Okay, ALS is also another motor neuron diseases. The brain and spinal cord nerves start to degenerate, and they kind of start losing all sorts of function, and it's unfortunately rapid and debilitating death. You're kind of want to just consider what it is that you're doing, right, in each and every case. You want to get a good history. You're not necessarily going to be diagnosing patients, but you might have an idea, especially if a patient hasn't yet gotten a diagnosis. You might have a small idea, like, dementia patients, or patients, who are all of a sudden progressing in their dementia disease, Parkinson's, or there's some sort of change that was otherwise not there. But if you have a patient who's having a hard time breathing, you're going to treat that first. And then you're going to worry about what's the root cause of their breathing troubles after you've addressed it. But you want to, put all the pieces of this puzzle together so that you know what's going on. All right. Let's take a 5-minute break. Come back for the system. Finish our other 2 lectures for the day. Okay. So in 5 minutes. Having a rough speak. It's such a Monday. All right. Immunology. So I feel like everyone kind of got probably a good crash course in immunology brought to you by COVID. Right? We're very familiar with how the immune system works now. But your most important parts of your immune system are your spleen, which does a really good job of filtering your blood. It's also a reservoir for your blood. I believe it's like about 500 milliliters of extra red blood cells and such that lives in your spleen. So if you go into some sort of hemorrhagic state, your spleen's like, be free, and it helps kind of bolster you for a little bit before you die. Then you have your tonsils and your adenoids. Some of you, I don't know if anyone's had their tonsils out when they were kids. those live in your throat. This is the commonly
I
mom,
have
I
all
don't feel
that out.
good, I don't want to go to school. You got them out?
All of it, yeah. And decreases my chance of having strep. I've only had it once in my entire life.
I also got them out.
Usually they make you wait. Like if you're a kid and you have strep throat, they make you have like strep throat like 20 times or something, like in a short period of time before they actually take them out now. Like
Mine
that's
wasn't
pretty
for strep. It was for snoring when I was like, I think I was 5.5 years old because I was just starting kindergarten and then I was out for like a month.
yeah. You were
I
like
had a really
Mine,
bad
this
reaction
5-year-old who had
afterwards.
horrible sleep apnea.
I was the kid who was like too short. Like you needed to have X amount a year, and I'd always come up like 1 time short, so they left mine in.
That was me too. But I had mono, I had strep, I had everything 1 year, and they were still like, no, okay.
They
Oh
want you
yeah,
to
Yeah.
keep tonsils generally.
They don't take them out anymore. They take primarily for that breathing, for the snoring and for other kinds of sleep apnea.
Unless
yeah, I
you're in
had bad
Russia, in which case they just
snoring.
take them
Yeah.
out without any anesthesia.
What's that?
There's a video on YouTube. In Russia, they just take kids' tonsils out. Like they just line them up, they open their mouths, they go thump thump and pull them out, and that's the end of it. Carry on.
Oh,
Yeah.
My
I
my
don't.
mother had hers out with Novocaine.
When my throat gets inflamed, what are they called? Oh, kissing tonsils. That's what, like, my tonsils just get huge, and literally they basically touch. So, and they're still like,
Worse.
no.
Good. You should be like, I can't breathe.
Yeah, then they're still like, no, not covered. Okay.
So then you have
it's-
your lymph nodes, right? So we have lymph nodes, a lymph system that goes throughout your entire body. You'll most likely, if you ever have like an infection somewhere, you'll feel like in your groin or in your armpits or up here in your neck that they swell because they filter out the junk. Um, your blood goes through your lymphatic system all the time, and then it filters it and it puts the plasma and stuff right back into your bloodstream. This is why when you have patients who've had mastectomies on one side or the other and they taking the lymph nodes out, they don't want you to squeeze that side. When you squeeze the capillaries and such, it squeezes into the lymphatic system and then drains it right back in. If that lymphatic system isn't there, then you just have swelling, and it takes a really long time for that swelling to go back down. And then you have the thymus, which is what creates your T cells, because we're very clever when it comes to naming things here in medicine. T cells from the thymus. As a small child, the thymus is much larger, okay, and it lives right behind your sternum. As you get older, the thymus becomes smaller because it's not as, I guess, necessary because your body's immune system as a whole takes over. We're not going to. So we have what's called antibodies, right? Your B cells, your IG, the two most important ones that you really see that are really tested for, especially when you're having a like your titers checked, are your IgG and your IgM. So your IgG is you have a current infection. Your IgM are your memory antibodies. So your body's made them. If you have another influx of this whatever virus, bacteria, whatever that comes into your system, your IgM is what comes and creates IgG for you. And then you have IgE, which is really what's involved in like allergy responses. And then you have IgD, which no one knows what's going on. They're like, it's there, it does a thing. Then you have your T cells, which are some of my favorites, right? They're your lymphocytes. They work with your antibodies. Killer T's are by far my favorite because they just kind of the ninjas of the body. They kind of move through and just slice things up. So they work with the B cells to produce antibodies and they suppress your immune response from going out of control. So if you have a person who has an autoimmune disease, their suppressor T cells are not doing what they're supposed to do. So you have basically within your bloodstream and within your gut, you have all of these undeveloped white blood cells that then get based on what the antibodies detect and based on what the T cells start being produced, will turn into different types of white blood cells. Different types of white blood cells. So you have basophils, neutrophils, eosinophils and monocytes, which monocytes turn into macrophages. Macrophages just envelop them and eat the bacteria or whatever. Depending on what you're infected with, bacteria, virus, or fungus, depends on what combination of white blood cells down here. Oh, let's see if it writes again. Nope. Combination of basophils and neutrophils and eosinophils, etc., will be produced. So, for example, I believe if you have a virus, you'll have very high eosinophils and very low neutrophils. Okay, and that's how they kind of determine, based on a white blood cell array or assay, not array, assay alone, what kind of infection you have even before they get cultures back. So if they're like, oh, you have this, this, and this, oh, it's going to be bacterial, let's do broad spectrum antibiotics. If they get it back and it's like a viral, they're going to go, okay, like maybe we can do an antiviral, maybe we can just support your immune system in a different way. When you said this, all of your B cells and T cells and monocytes live within your body, so that at different points of entrance, if you have another antigen coming into the body can respond faster and can produce the white blood cells that you need to fight it. This is why, vaccines work, because we're programming your body to recognize different bacteria or viruses, et cetera, et cetera. This is why when you get sick with something the first time, you can't necessarily get sick with it again. So for example, if you've had mono, right, you usually don't get mono again because your body's like, I recognize this, knock it down, okay? And it sends a much more pointed response than if you had never had it in the first place, okay? It kind of cuts it off at the knees. So you have natural immunity versus acquired immunity. So your natural immunity is just non-specific. You have white blood cells, they will attack things that are not self. You have it from birth. You get a little bit of extra antibodies from the placenta and from breast milk. So breast milk fed babies tend to get sick less because they're still getting certain amounts of antibodies transmitted to them via the breast milk. So mom's immune system is still protecting them. IgG, right? So if mom has any sort of infection or whatever during pregnancy, those come through as well, so that the baby is somewhat prepared, so that when they're presented to these things in the natural world outside the womb, they don't just die, okay? Because they're small and they're little and they don't have a lot of strength to do a lot of this fighting. This is why when you see newborns who are very, very sick, that's a big problem, okay? That means they've gotten hit with something that was unexpected, okay, that mom didn't have an immunity to. This is why whooping cough is so dangerous for little kids, because that, on top of the fact that they have a hard time breathing and kids are super respiratory driven. This is why, we have them get their vaccines when they're little so that we can build up their protections. So which vaccines are part of your acquired immunity. Not only are vaccines a part of your acquired adaptive immunity, but they're also whatever you're exposed to. So Casey, you had mono. You have an acquired immunity to mono. Actually, most kids in the world have had mono before. About 80% of people have already been exposed to mono by the age of 5. And that's due to little kids putting things in their mouths while at daycare. The very common virus is just around. So once you have that memory, it's there for long term. It's called titers, okay, if it's given to you via a vaccine. You can run low on titers, which is why we have booster shots, which is why you should get a tetanus shot every 10 years. And there are some people who do not serum convert, okay? So they might get the shot and their body's like, hey, that's cool. Yeah, that's all I'm doing with it. I'm not really interested in making antibodies for you. So they'll never, even though they've gotten the vaccine, they'll never actually get an immunity to it because their body is just like, whatever. So we talked about this. right? So you have active is I've had to get sick or I've had to get a vaccine, right? I've actively had to do something, or passive, which is maternal antibodies that are passed on. Mom did all the work of getting sick or getting the vaccine and gets to pass it on to baby. Or artificial, which they were doing with COVID. They were giving people monoclonal antibodies derived from people who already had COVID. So you have 4 different responses brought to you by the immune system. The immune system is very good at distinguishing what is self and what is non-self until you start throwing in autoimmune diseases into the mix, but we'll talk about that in a little bit. Memory cells give you that rapid response for the same antigens. Why we get like, the flu shot every year. If it's the same strain, we're good every year. We recognize that your body's like, not today, Satan, and that's the end of it. You have antigen-specific antibodies for new exposures. Okay, so just because we've memorized stuff doesn't mean that we can't make new stuff. And then we have a self-regulated when a pathogen invades. We are not always making these antibodies. So these antibodies will only really be found floating around when you are potentially exposed or sick. The problem with, I guess not a problem, but sometimes some people have hypersensitivities to antigens. Okay, it could be bees, it could be pollen, right? It could be almost anything in the environment that your body is is a little sensitive to, right? It has maybe made too many antibodies, and now the response is going to get excessive. I knew a kid in college, rest in past, who was allergic to everything except for pork, greens, and potatoes. And he actually died from an anaphylactic reaction a few years after he graduated. So your body is really good at what it does, but when there's no, governor on the system, it can go a little nuts. So if you are oversensitive to certain antigens, you can have an allergic reaction, right? So your allergic reaction, you usually get itchy eyes, a runny nose, vomiting, diarrhea, hives, right? Your body is essentially trying to do 2 things. One, it's trying to sequester the antigen, right? So that's like your hives. Okay, you maybe touch something that you were allergic to, and your body's sending all sorts of white blood cells, histamine and heparin around into that area to keep it there. And it's then trying to get it out of your system also, right? This is your runny, your runny nose, your scratchy eyes, vomiting. Your body just wants it out. Your body is very good at recognizing if it's exposed to something it's overly sensitive to. So you have these 2 delightful cells that help trigger the immune response. It's your mast cell and your basophil. So your mast cell is sort of like, the confetti tubes that they sell on Amazon now for gender reveals? That's a mast cell. So an antigen exposes itself or reveals itself, and the mast cell goes and explodes everywhere, and it starts to release histamine and heparin and other cell-mediating chemicals to an area. So the histamine causes, that itching. The heparin thins the blood in the area, so it doesn't go too far. And then you have the basophil, which is one of your white blood cells also, and that comes and also kind of explodes in the area and tries to, again, sequester the antigen. Different types of hypersensitivity reactions. So you have, it goes, from most intense to least intense or vice versa. So you have an immediate reaction, right? This is like sneezing. Then you have cytotoxic, which is specific to the tissues. So if you have brushed up against something, you're going to, that you're allergic to, you might have a rash or something to that effect. Then you have complex mediated reactions, right? And you have your mast cells and basophils start getting involved. And then the delayed reactions, when the cells, the more histamine and everything else starts to get involved with the in the reaction. So we talked about this a little bit, right? So your allergen bridges antibodies. So this antigen comes in, it has the specific shape on it for the antibody to recognize it, and the whole system starts to go into warp speed to get rid of it. So your mast cells will start to release histamine, and then you'll start having the actual allergic effect. So allergic reactions are relatively mild. When you start increasing the response, right, and you're ending up with angioedema, which is like that facial and airway swelling, that's when it becomes an anaphylactic response, okay? And we're going to start talking about anaphylaxis and all the other things that happen in anaphylaxis right now. So anaphylaxis is full-blown systemic, okay? It is a life-threatening allergic reaction. You need to recognize this and have a low threshold for, where life-threatening lives. So most, like hallmark, you have the angioedema, right? So you have a facial swelling, the airway swelling. The airway swelling will then start to lead into stridor, right? So you might have vocal changes, difficulty breathing, drooling, okay? Then it also leads itself into wheezing and bronchospasm because now it's systemic, right? So you have histamine all over the place and it's starting to create this very tight response because remember, the body is trying to keep the allergen out. So if we shut down your airway, the allergen won't get in, which is great in theory until you need to breathe. Okay? And then you have on the GI side, right? The same thing. We're going to get everything out. So vomiting, diarrhea, cramping, okay? Because your body is now going into overdrive to get everything out of the system. Same thing with the cardiac, right? Your heart rate's going to increase because now we're increasing blood flow to get to the kidneys and the liver to start filtering out what might be there to get it out of your system. The problem now is that histamine more or less punches holes in your vasculature. It makes it very leaky. Okay, so let me see if I can get the doodle. You know me and the doodle. All right, so you have, right, here's your blood vessel. So now the histamine comes by and it starts to increase the space between those, each capillary is one cell. The histamine comes by and increases the space. So now as that space is increased, your blood starts to go out, right? The plasma starts to leak out also. So now you just have you have red blood cells pretend those are red blood cells, floating around without as much plasma, right? You start to lose the plasma. So this is why you see the swelling also, because the plasma starts to third space, right? It ends up in that space between the capillary and the tissues where it's completely useless. So this is why we give patients the Benadryl, because it's an antihistamine. So it reduces the response of the histamine. This is why we give them the epinephrine, because it starts to dull the response to the allergen and starts to constrict the blood vessels and tighten everything back up so we can bring that plasma back in and be useful. Okay, this is why these patients are going to require some fluids. When you have over here, you have your wheezing and your bronchospasm. We treat that with the albuterol. Okay, the only thing that we don't do for anaphylaxis in the field is Pepcid. They will give the patient Pepcid to help treat the GI stuff. That's it, because Pepcid is a H2. You have H1 and H2 histamines. Okay, Pepcid is the only thing that we don't do in the field. Other than that, we 110% treat every single aspect of anaphylaxis in the field. It's one of the most satisfying protocols you'll get to do, because you'll get there, you'll treat the patient, you'll do everything. The patient will feel fantastic. You'll get to the hospital and they're like, great, you did such a good job. Okay, put them over there. We'll keep an eye on them and make sure they don't need anything else. Steroids, the only other thing, right, that wasn't involved. Steroids do the same thing. Solidifies that cell wall so that the fluid isn't third spaced and everybody is happy. Angioedema. The problem with anaphylaxis is it's very fast moving. So your patient might be very, 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 very sick by the time you get there. Okay, especially if they didn't recognize it right away. If it's one of the first times that they've had it, they might not recognize it as anaphylaxis. Oh, it's just an allergy. Okay, every time that person is exposed to the antigen, their risk increases and their risk of death increases. So you need to, again, have a low threshold. If a patient's looking a little edemus, right, a little puffy, maybe you need to go straight to the epi. Okay. Here is a little fun infographic. The most common and most deadly allergen is usually a bee sting. Okay. The whole family of bees, wasps, fire ants, those guys are deadly. Most commonly, peanuts are very fatal food allergy, as is shellfish. Um, when it comes to food allergies, people are, if they know they have a food allergy, I want to say about 80% of them are really good about avoiding those foods. Then you have the other ones who are like, whatever, it's fine. But they might not know. I had a kid once who was allergic to peanuts. He went to a Chinese place, had Chinese food, and he started getting the itchy throat. And he was like, oh no. Ironically, he was a journalist writing for a running magazine because he was a runner, staying in Queens, and he jogged to Walgreens while having the beginning of an allergic/anaphylactic reaction and chugged the majority of a bottle of children's Benadryl. Promptly threw up, finished some more Benadryl. Didn't realize that the Chinese food that he was eating was cooked in peanut oil. Okay, so there's hidden ingredients in a lot of like prepared foods that people might not be aware of that will trigger their anaphylaxis. Also had a girl once, or a kid once, he was allergic to fish. He was upstairs taking a nap. The family was downstairs cooking fish. The smell of fish alone put him into an anaphylactic reaction. So just because they might not have had like a direct exposure to their allergen doesn't mean that they aren't going to have a response. Always make sure if your patient has an auto injector, if they've given it to them, there is a secret second dose supposedly in an auto injector. So if also make sure that they've given it to themselves appropriately because they have to hold it there for 10 seconds. And bring them to the hospital. So you have your exposure, the antibodies are produced, and then they start to bind to whatever's causing them to have been produced, the antigen. The antigen is then reintroduced to the system, and the chemical mediators are released, your histamine, your heparin, and all that, and then anaphylaxis starts. Here are a list of the chemical mediators that are involved in an anaphylactic reaction. We kind of primarily deal with the histamines, right? That's what we end up treating. But there's also heparin, right? Your body naturally makes some heparin to thin your blood. There's kinins, prostaglandins, thromboxanes, leukotrienes, right? These are all things that I'm sure you've heard in, at the very least, pharmaceutical commercials, right? These all do different things in so much as they create the whole anaphylaxis reaction. So you have this relaxation of the spaces between cells, fluids run out, and then your edema starts. Histamine is considered to be a protein. Mast cells and basophils release it, creates the permeability of your vasculature, dilates your capillaries and venules, right? So your patient might be red and flushed as well. The interstitial spaces start to get filled with the leaky capillaries, okay? And it also causes the contraction of the smooth muscle tract and the bronchial tree. Okay, histamine is really what we're treating when we give the patient Benadryl. The things it does, a lot, okay? A lot of different things that histamine does. And histamine is also just a kind of normal part of your system. It's just when you have too much of it that it becomes an issue. Leukotrienes, they're a precursor for prostaglandins, okay? They are released by mast cells. They are also bronchoconstrictors. So we fight the leukotrienes with albuterol, okay? Some patients might not actually end up having a super potent bronchoconstriction response in their anaphylaxis, okay? Or you might not be able to hear lung sounds at all, so just be careful, okay? Also contributes to vasoconstriction and increased vascular permeability, right? So you're losing a lot of fluid. Fever, chills, bronchospasms. It attracts these chemical chemotactic factors start to bring everybody else to the area. They pretty much send up a flare saying, hey guys, here's the problem. Everyone come on down, and it causes all of the extra response, okay? So when you're doing your assessment, getting a good history, no matter what, getting a good history of what's going on is essential, okay? What were you exposed to? Do you have known allergens? Okay. Know the difference between your tree nuts and not tree nuts. Like for example, peanuts are not true tree nuts, so a patient can be allergic to peanuts and not like walnuts, okay, because they're different types of nuts, different types of protein. But you will potentially have a patient who looks like they're going through could be a number of different things, right? So they might sound like their lung sounds might sound like asthma, right? Really bad wheezing, or their airway might be so closed that it sounds like they have a foreign body airway obstruction. They might have fluid in their lungs from that interstitial third spacing, okay? They might have a whole slew of different presentations, but you need to know, right? You need to know the right questions to ask. You need to make sure that you're in there and you're making sure that you cover all your bases. Right, so we talked about a lot of the respiratory effects already. Patient will be hypotensive. That's a severe anaphylaxis, right? You might get to them right before they get super hypotensive. Especially if you have a small child, make sure you lift up their shirt to check for urticaria and hives. Okay, doesn't even in adults, you might not see it. It might not be evident on their arms or neck or face. So you should lift up a shirt to get a full assessment. Oh, excuse me. I've also had patients who have pointed out, skin conditions that they say, this is what my hives look like, okay? Especially people with darker skin might not be as obvious in terms of what a hive looks like, okay? Ask them if that's normal, if they've ever experienced that before.
Yesterday
Mhm.
in the peds ED, there was a kid, a little baby, maybe 8, 9 months old. I forgot what it was, but came in and he was sniffling, and like you would almost like what those first signs of like not necessarily anaphylaxis, but just allergies, right? Like that look of allergies. And he's all like congested and whatever. And you pick up the kid's shirt and you see like all redness on him. And I was like, is this kid having an anaphylaxis, right? I'm looking at him and it looked like hives almost. And the doctor comes in and we're like looking, and I'm like trying to like look, and I'm like, it doesn't really look like normal hives. And it turned out it was actually an upper respiratory infection, but the kid had eczema.
Yeah.
And
So
so it was
kids,
like it totally looked like anaphylaxis, like starting,
yeah.
but
And
it
kids,
wasn't.
eczema is actually like an autoimmune. So it is, to a certain extent, it does fall into the immunology category. Kids who have eczema are also at increased risk of having asthma. Okay, for some reason those are kind of tied together. Um, so yeah, that's a great pickup. But making sure that you check the kid's chest is important.
Yeah, so
Yeah, but also kids aren't necessarily like they're itchy. They might just be rubbing, right? Kids don't necessarily scratch like the way adults do for hives. So it might just look like a rub, like how kids pull the ear for like an ear infection. Same kind of concept. They might just be rubbing or kind of look uncomfortable and they're
so
itchy.
with that kid, like I totally in the field would have looked at that and so thought anaphylaxis, and most likely I would have hit that kid with epi, not realizing.
Well, the
I
good
mean,
news
that
is
would
that
have been
kids are
cool.
really
Now
resilient.
I know to look for it, but if I didn't see that, I think
Yeah.
I would have been fooled.
And I mean, but at the same time, you're doing probably what you thought was right by this kid because you're preventing them from going into what could be anaphylaxis because the one time you don't act quickly could be the one time that they do go into anaphylaxis. The good news is kids are relatively resilient to epi. They can tolerate that increase in heart rate because they're usually relatively healthy. But yeah, sometimes it's hard to tell the difference. Right, so some things that you might notice when it comes to the airway is that there might be some like changes, right? They're complaining of like a scratchy throat. Their voice might be changed, might not be very loud. It might be very kind of raspy. Barking cough, where it sounds like that seal bark, right, of epiglottitis. Sort of like when a kid is having epiglottitis, is because that's edema of the whatchamacallit, of the epiglottis, angioedema, shortness of breath, wheezing, okay. Um, Patients who are going into anaphylaxis can deteriorate really quickly. So you want to make sure that you support their blood pressure. You're going to get them some fluids. Look at your protocols, okay? Look at the protocol for anaphylaxis, okay? You can give, I think it's up to like 2 liters, a liter or 2, without calling medical control because you want to support their not only their circulation, but support the clearance of whatever the antigen is from their body, okay? It's kind of twofold. Usually, anaphylaxis will occur within the first 5 to 30 minutes of exposure. The difference being the oral exposure, right, might take a little time. It takes about 20 minutes to digest something. So if they're allergic to egg protein, it's going to take maybe 20 minutes for that egg protein to get into their system, and them to start having a response. Injection is the fastest route of the fastest route of an antigen to enter the body. Okay. Um, inhalation and um, inhalation is also very quick. Patients who have asthma, right, could be complication. Beta blocker usage, right, because maybe they aren't able to compensate tachycardic wise. Yeah, 20, there you go, 20 milliliters per kilogram, and a max of 3 for your fluid for your anaphylaxis patients. And always make sure to see if the patient has had an EpiPen or deliver themselves an EpiPen prior to arrival, okay? Because that might change your course of action. If they've already given themselves 2 EpiPen and it's not getting any better, right, maybe you need to call medical control. Maybe they are going to want, something else, or a larger dose, or they're going to want a drip, or they're going to want you're going to have to notify the hospital so the hospital can get them set up for an epi drip. Okay, it could be a number of different things. We talked about all of these. Make sure that you're doing effective lung sounds. Okay, because you might say, oh, it sounds clear, but it's only clear up here. The air's not getting any further down, right? So make sure you get good lung sounds. Make sure you listen for wheezing and fluid. Always put the patient on a monitor, especially if you're going to give epi, because epi can put them into dysrhythmias. Have to double check. Yep, there you go. Right, so here's your key interventions for anaphylaxis. Okay, 0.3 milligram of epi 1 to 1,000 IM. It's weight-based if it's a child. Okay, 50 milligrams of Benadryl. 125 of salmeterol, albuterol, up to 3, I believe it's up to 3, and the max of 3 liters of saline. If things are getting a little dicey, you can also ask for other medical control orders for a pressor to help improve blood pressure. All right, so now here's some random diseases that we're going to talk about real quick that aren't really going to be one of those things that you diagnose in the field. The patient may have, but is not necessarily going to change the way you're treating them. Because remember, you're going to be treating them similarly to everything else. If they have a respiratory problem, fix their respiratory problem. If they're having chest pain, deal with their chest pain. So here we go. So collagen, right, is the structure of most of the bodily tissues that you have. Okay. there's different things that can cause collagen issues. This is really where your autoimmune diseases kind of pop up. Okay. So if they're doing any sort of testing for this, it's going to end up being your, right, they're testing your rheumatoid factors, your ANAs, anyone who's ever had to deal with, whatchamacallit, any of these workups, or they'll tell you patients take average about 7 years to have autoimmune disease actually diagnosed. Most autoimmune diseases tend to affect women more than men. About 80% of autoimmune diseases occur or found in women. Your body just goes, oh, this isn't self, and starts attacking. Most of the time it will affect, it's the collagen that it's attacking, right? So it's specific. So it could be that it's attacking muscle, it could be attacking blood, skin, any sort of anything, okay, or all of it. So for example, you have systemic lupus, okay? It will literally attack almost every single system in the body, okay? A lot of these patients will be on, or potentially be on, immunosuppressants, okay? That could be Humira, it could be infusion that they get once a month, okay? It could be a number of different things to keep their immune system from attacking otherwise healthy tissues. This means that they could have plenty of other side effects that, you wouldn't otherwise expect because of the disease. So maybe they have lupus, but maybe right now they have a really bad upper respiratory infection because they're taking immunosuppressants, okay? This is why COVID was such a big deal for a lot of these patients. There's your traditional butterfly rash of lupus, okay? It usually comes across the nose and into the cheeks. Again, you're probably not going to be diagnosing lupus in the field, but patients might be presenting with a number of kind of vague symptoms that will eventually end up kind of being diagnosed. Scleroderma. Bob Saget's sister died from scleroderma. If you would like a really depressing Hallmark movie, there's a documentary about that. Basically, what happens is it attacks the collagen in the skin, and it causes the skin to produce high levels of collagen because of the attack. And then it basically turns the tissues into like rock. Okay, so they can very, very, very hard. Not only can it affect the outside skin, but it can also affect the tissues inside the body, which can result in like, GI disturbances, blood vessel narrowing, stuff like that. This could cause you some difficulty if you are trying to start an IV on a patient. But again, these are things that you're not going to be diagnosing, you might just see. Scleroderma can also be localized, or can it cause necrosis? No, it's causing too much collagen. So like, when you have like a really big, a keloid scar or something to that effect, it's not killing the skin, it's producing too much skin. So scleroderma can be localized where you have patches, or it could be linear, so it's occurring on one side of the body as opposed to the other. When it goes systemic wise is when you start having patients who have bigger issues, because it's developing organ involvement. Raynaud's, if anyone's unfamiliar with what Raynaud's is, it's the tips of one's fingers will have such severely restricted blood flow due to narrowing of the blood vessels that they turn white or purple. So it can be involved. It can cause like this very like tight looking shiny skin. Usually it happens over the first 3 to 5 years, and most damage. And since it takes 7 years for an autoimmune disease to be properly diagnosed, you could be up the creek without a paddle of damage, of irreversible damage, because it's already happened. A lot of dysfunction in like the areas where like tissues are constantly being replaced, like for the example, the GI tract, right? You need the GI tract to be kind of, pliable so it can digest and absorb nutrients. So, transplants. So, Kidneys are the #1 most commonly transplanted organ in the United States. Other than that, there's always people getting who are requiring transplants. The problem with transplants is that these patients need to be on long-term immune suppressants so the body doesn't attack it, because it is very clearly not yours, right? Your body knows. Unless you're getting an organ from an identical twin who has the same exact DNA, it's going to try to reject it. Even if it's an identical twin, it's probably still going to try to reject it because it's like, it doesn't smell right. So the good news is that the narcotics epidemic has given us a surplus of organs, of young, healthy organs, which is kind of depressing if you think about it. A lot of different complications. Most of the complications are due to the long-term immunosuppressants. So you have patients who have very low white blood cell counts, get opportunistic infections. They're the ones who kind of need the flu shot every year, who right now in the world of COVID are like probably most terrified. All sorts of different issues. One thing I will say when it comes to transplants, if you have a patient who has received a heart transplant, and I learned this from a transplant coordinator while I was on scene with a heart transplant patient. If they are tachycardic, they cannot get adenosine. Adenosine will not work because when they transplant that heart, they do not have the ability to set up all of that nerve pathways, so the adenosine doesn't have that parasympathetic effect. They need to be cardioverted if it is a life-threatening tachycardia. However, the first thing that most transplant patients will tell you, especially heart transplant patients, is here's the phone with my transplant coordinator. They're going to tell you everything you need to know, and I probably need to go to this hospital. Okay. So you'll kind of know. Liver is I saw that waiting on a transplant list, a lot of patients who die. Patients who have something like cystic fibrosis is their only way to live a normal life. Okay, there's a lot of patients waiting for transplants who will not be able to have a normal life otherwise. So various things that can kill you, right? All of your virals, okay? If they do a really good job now of kind of clearing transplant organ donors of different medication or different virus issues or infectious issues. So you might have a patient who is rejecting an organ. Okay, most of the time this happens relatively quickly. The body's like, what? But at the same time, if a patient forgets to take immunosuppressant drugs, even 1 or 2 doses, they can start rejecting that medication, that organ right away. A lot of it sort of starts to look like flu-like symptoms. They'll be achy. They won't feel well. Anything that you kind of would have associated with like getting a vaccine, like when you feel kind of like crap the next day, is kind of what they're going to be feeling. But you'll also potentially have pain at the site of the transplant where the body is rejecting it. A lot of different things. Bone marrow, I think, is the only one of the few transplants that the patient doesn't require long-term immune suppressants. Heart valves, when they're being transplanted, might not be human. They have porcine and bovine. Okay, so those also aren't necessarily going to be they don't require immunosuppressant drugs. And also stem cells. Okay, stem cells are kind of super non-specific. So when they're being used, the body doesn't recognize them as non-self because they are kind of like generic cells that aren't DNA specific at that point. Yeah, stem cells. Stem cells are like the new black. They are being used for absolutely everything, and it's really cool because patients are having better outcomes because they don't have to take those immunosuppressants. Um, a lot of times patients can have bad reactions to their immunosuppressants. Here's a couple of names of different medications that you might see. Prograf and cyclosporin. I've seen a couple of times. Okay. Um, just kind of be familiar with them, because then you have to kind of change your way of thinking as like why this otherwise healthy looking patient is so sick because get the immunosuppressant drugs, or maybe you need to take into consideration what kind of organ transplant they had. But most of the time when they transplant organs, they're like new and shiny. So even like when I had that gentleman who had a heart transplant, he was having chest pain. It was extremely unlikely that he was having a heart attack because they're not going to give you a diseased heart. They don't want to go back in and do another surgery. They want you to have a fresh, clean, shiny heart. Any questions? We're done with immunology.
Yeah, I have a question.
Go ahead.
So, I'm just trying to understand like the collagen. Wait, so when people put like Botox in their face, is that what is that?
That is, they are injecting a toxin, a botulism toxin, into their face to paralyze the nerve.
Okay, I don't know. I don't know. I thought that they were injecting collagen. Do people do inject collagen into their?
Yeah, so injectable collagen and stuff like that, it's like a filler. It's like extra.
Okay,
It's
I just want
yeah.
um
When your body makes its own collagen in excess, that's when it's an issue. Because
okay.
like collagen that they're injecting is going to dissipate after a while. It's sort of like saline or breast implants.
And that disease is like an excess of collagen, right?
Yes,
Okay.
scleroderma. Yes.
And I don't. This isn't a question, but I seen this maybe like a year ago, which is really cool. And like I actually seen the patient. They did the test. Like I don't know if they were doing a test, but they injected stem cells in a person who had a stroke, and he actually recovered within he got like most of his function back. It was pretty crazy. So they're doing a lot with that. So
Yeah, they really are. It's really impressive the amount of like science that's kind of coming to fruition now when it comes to stem cells and stuff like that.
yeah.
The problem is insurance doesn't cover a lot of stem cell therapies. Um, they use stem cells for a lot of like musculoskeletal issues. So like if you've torn a muscle or ligaments and stuff like that, they can inject it and hopefully help it regrow to be stronger.
It helps. All right, thank you.
No problem. Any other questions? All right. So endocrine. You will see a lot of endocrine, and by a lot of endocrine, most likely diabetics. So, quick overview of the endocrine system. Um, the endocrine system are ductless glands that secrete hormones directly into the bloodstream. So they don't have, um, you know, tubes or anything like that. They just right to the bloodstream, and hormones produce changes in the body. Okay, some of them are long-term changes, some of them are short-term changes, depending on what the hormone's purpose is. So any disease processes that we see are due to either too much hormone, not enough hormone, or issues with the hormone receptors. Okay, so you have up in the head, we have the hypothalamus, the pituitary, and the pineal gland. You have the thyroid and the parathyroid here in your neck, your adrenal glands, which sit on top of your kidneys like fun little hats, your pancreas, which you're probably the most familiar with in terms of being part of the endocrine system because we talk about diabetics all the time, and then your ovaries or testicles, depending on how biology treated you. So we have the different types of hormones that we have are your steroid hormones. Okay, so these are the ones that are synthesized from cholesterol. So they have you know, we use cholesterol for a lot of different things in the body. One of them is to make steroids. So patients or people who are on, like, you know, statin drugs sometimes have an issue with some of these, making sure that they have enough hormones. These are, you know, cortisol, aldosterone, estrogen, progesterone, testosterone. Okay, these are your steroid hormones, as opposed to your non-steroidal hormones, which are from amino acids, which are proteins, not fats. This is insulin and your parathyroid. Everywhere in your body that needs to be affected by a certain hormone has a receptor for it. Okay. If we use, I guess, let's use, since everyone's kind of familiar with it, if we use insulin. Okay, your insulin has hormone receptors on every single cell in the body because insulin opens up the gate to allow sugar into the cell so the cell can use it as fuel. Okay, so if it was very specific, so for example, there is a hormone that only worked on certain cells, certain tissues, you could inject that hormone till the cows come home and it's not going to affect a cell that doesn't have the receptor on it, okay? It's very specific, a lock and key kind of mechanism. Your body uses hormones through two different feedback systems. So you have a positive feedback system where it's moving away from normal, which is most commonly seen during childbirth, right? Oxytocin is a hormone that's produced in the hypothalamus, I believe. Yes, hypothalamus. And it promotes muscle contraction, smooth muscle contraction. So the more it produced, the more it causes the uterus to contract until the baby is delivered. When the uterus doesn't have to do work anymore to push a baby out, the oxytocin stops. Positive feedback system. The negative feedback system is something to the example of like insulin. So you eat sugar, right? Your body goes, too much sugar, quick, bring it back to normal. And it sends out the insulin to the body and puts it into all the cells until you're back at a normal range, okay? And then when it's done, when you get back to that normal range, there's no more insulin being secreted. Here's another example of how that works, okay? These are negative, feedback loops, right? So you eat, as you eat, your blood sugar goes up. Your pancreas says, "Hey, guys," it secretes some insulin. All your cells get the glucose. As your blood sugar starts to drop, it stops the insulin, okay, until you eat again. As opposed to fasting, when you start fasting, your blood glucose starts to drop. Your pancreas is like, oh God, we need glucagon, right? Because glucagon helps release insulin from the liver, release sugar from the liver. As you start to release glucagon, your insulin goes down, your glucose goes back, your glucose secretion goes up, your blood glucose improves, and you're going back around the circle again, okay? Your body is very, very good at maintaining this balance. So we're going to talk about some of the disorders of the endocrine system that you might encounter. Diabetes, okay? Diabetes type 1 is considered to have a bit of an autoimmune disease process. There's something that causes the pancreas to dysfunction, and your body doesn't metabolize food properly, especially carbohydrates, okay? So as you eat, right, your body, at the most simple level, your body breaks down carbohydrates into simple sugars, and that needs to go into your cells for fuel, right? We talked about the Krebs cycle and the how energy is made. Insulin is one of the primary regulators of your glucose level, okay? It keeps it from being too high. Your pancreas produces insulin from their beta cells. It produces glucagon from your alpha cells. And then your delta cells, it gives you somatostatin, which is another hormone that helps in the regulation of not only your insulin and glucagon, but also growth hormone. Okay, so you know those bodybuilders, that's where they fuck around with and somatostatin. Okay, so you have three types of cells in your pancreas. Beta cells produce and secrete insulin. Alpha cells produce and secrete glucagon, right? So insulin brings your sugar down, glucagon brings your sugar up, and then your delta cells, which produce and secrete somatostatin, which kind of is the regulator in the middle. It kind of keeps everybody in check, as well as your growth hormone. So we talked about how hormones are your lock and key. Insulin comes, it floats on by, it finds a receptor, it locks into the receptor, it opens up the glucose channel, and lets glucose filter into the cell. The cell is very happy at this point. Yay, I've got me some sugars. And it uses the sugar to make energy. Okay, especially in your brain, you need oxygen and sugar. So insulin is essential for getting glucose into your brain. This is why you have altered mental statuses, right? So it makes sure it keeps your blood glucose in a very normal range, okay? Normal range is 60 to 100-ish, 120, depending on who you are and how you eat, okay? Insulin versus glucagon, they're two, like, they work on opposite sides of the spectrum. So glucagon is secreted by the pancreas, goes to the liver, and goes to the liver and says, "Hey, bro, we need some more sugar. This one has decided we're gonna fast today, which is rude, and I'm hungry, and these cells need some sugar." So it stimulates glyconeogenesis, which is the breakdown of fats from fatty acids. But it also stimulates glycogenolysis, which is glucose being released from glycogen. Glycogen is a complex sugar structure where that lives inside of your liver, okay? So when you eat, any sugar that you aren't used, any glucose that you're not using gets turned into glycogen for storage, okay? Now, fragile diabetics, okay? Anorexics, patients with really, really low blood fat or body fat, okay? Might not have good glycogen stores. Glycogen is also stored in the muscles, okay? It's we carry glucagon. So if you give you can't get a diabetic an IV, maybe they have some really crappy veins that day, so you go to give them glucagon. That glucagon might not work very effectively because they might not have it much storage. Okay, so just keep that in the back of your mind when you're using glucagon, because it might not work as effectively as you think. Again, hormones work relatively slowly. So if you give someone glucagon, it's going to take a little while for it to actually show an effect. Okay, so you need to also keep that in mind. It takes time. Hormones are not fast. Now, somatostatin kind of hangs out with growth hormone. The anterior pituitary gland, okay, produces it and helps promote muscle growth. Okay, this is what bodybuilders take, as opposed to, in combination with steroids, right? They want to get big. You naturally have a certain amount of growth hormone promoted in your body. Every time you work out and you strain your muscles, your body says, "Hey, we need growth hormone because we're going to repair muscles." Okay, totally normal. The problem with growth hormone is not problem, like a problem in certain aspects. It tells the body to not release insulin. So now you're storing glucagon in the muscles. Okay, it it reduces the ability of the muscles to absorb glucose, using that energy up. 60 to 100, right, is your normal. Fasting blood sugar test should be less than 100. If it's not, if your carbohydrates are not instantly used, it gets stored as glycogen in the liver and muscles, or as adipose tissue for a long-term effect. Glucose, right, starts in your mouth. If you put a piece of bread in your mouth, you kind of starts to taste sweet already. Okay, the enzymes in your saliva start breaking carbohydrates down to glucose right away. And it goes down to swallowing, right? It goes to your stomach. Now we're adding acid to the mix. We're moving it around. We're shaking it up. Some absorption starts there of glycogen. glucose, burp. And then it moves into your small intestine where your pancreas gets signaled to start releasing insulin. Okay, the bile and it also to release bile salts. Bile salts reduce the acid. Okay, so that you're not burning everything all the way down. It also emulsifies fats. Okay, so it turns it, emulsification. You know, if you ever have like a greasy dish and you put soap on it and it turns it into like those little bubbles, those little globs, that's emulsification. Okay, here you go. Your carbs get stored as simple sugars, glycogen. Okay, fats are get stored as fatty acids or glycerol, and proteins are absorbed as amino acids. You need all of these three macronutrients in order to survive. They're very good for you. The process of digestion, as everything starts to get absorbed in the stomach and the duodenum, and the rest, it goes right into your portal vein and goes up into your liver where things are processed and synthesized. Okay, it's very important. Whenever this is why medications work differently after they go through first pass metabolism, right? Remember we talked about that in pharmacology? Same thing with food. Food goes through a first pass metabolism. After it gets broken down in the stomach, it gets brought to the liver, and the liver turns it into what the body needs. Carbs are great. I love carbs. They keep you moving. Carbs are very effective. Okay. Depending on what your body's needs are, will determine how much of the blood sugar, of how much glucose is stored. It's usually around 60%. Your body has a very complicated combination of insulin. Make sure that everybody gets what they need. If you exercise and then eat, you're replenishing the glycogen stores in your muscles. If you exercise and then don't eat, it will not do that. This is why it's important to fuel exercise. Because if you don't fuel, your body will then catabolize your muscles, okay? And then you will see negative results. Your brain needs glucose, 100%. It doesn't have a great ability to store glucose, but it requires it 100% time. Sugar and oxygen. Brain constantly needs it. Fat metabolism. Your fat. Some of the glucose that you do eat can be turned into fatty acids. This is why we have obesity problems, because we have low-grade processed carbohydrates that your body is like, we don't really need all this, but we'll turn it into fatty acids, and then starts to turn into triglycerides in your blood, and then adipose tissue in your body. If you are one of those keto people, when you break down fatty acids, it turns into ketone bodies. Okay. Without insulin, your protein storage stops. This is why if you work out and you don't eat after you start to catabolize your muscles, right? It starts to eat them because they are high energy. Okay, they require high energy. When you break them down, it turns into turns into energy. The problem is when you start to break down muscles, it causes a lot of byproducts. Okay, not a very clean metabolism. So things like rhabdomyolysis can happen, which is when your muscles break down and large proteins start floating through your blood, and it causes a significant damage to your kidneys. Okay, so get your macros. We're going to talk about glucagon now. Maybe. So insulin, right, it brings all of the sugar into the cells. On the other side, we have glucagon. Glucagon breaks down glycogen into the bloodstream. Okay, it helps make those big molecules into small molecules that other parts of the body can use. The liver is fantastic. The liver is a great buffer system. The only problem with the liver is it can only do one thing at a time. So if you want it to digest and break things down properly, then it can't be cleaning your system from a night of binge drinking. Okay? It does a fantastic job of taking all the extra glucose that's floating around in your system and turning it into a complex glycogen, and then bringing it back out into the system when your body requires it. You know, your body doesn't want to be left without a backup source. So, it forms that negative feedback control. So when your blood sugar is high, you secrete more insulin. When your blood sugar starts to drop below the normal range, it starts to create glucagon and then back around the other way. Okay, your body does a very good job of keeping it in this very narrow range that's optimal for you. So one of the reasons that we have that fight or flight response, or that like the tachycardia, the diaphoresis, and all that other stuff when the sugar starts to get low, is that low glucose causes the secretion of epinephrine. Okay, because epinephrine has some glucagon-like effects, right? So we talked about back in the beginning of this class is that when you have epinephrine, like, right, you have that fight or flight response, you reduce epinephrine, your body's being primed to flee. And if you're going to flee, you need energy. Okay, so the epinephrine helps in the absence of glucagon. Growth hormone and cortisol also help reduce, maintain the blood sugar a little bit, but again, this is in the sense of stress. The more stressed you are, the higher the glucose production, but that doesn't necessarily mean that you're going to have the insulin necessary to put it in the cells. Okay, so you just end up with high levels of like blood sugar when you don't necessarily need that. Come on. So, diabetes. So this is one of those state test questions that usually pops up. You have a patient who is experiencing the adrenal gland lives on top of the kidneys. Talk about them in a little bit. You have a patient who's complaining of increased thirst, increased hunger, and increased urination. Family says that, nothing has changed. What is your differential diagnosis? Okay. Polyuria, polydipsia, and polyphagia should be your buzzwords for diabetes. Okay. So and this is especially in the younger children who have yet to have been diagnosed. Okay. When you don't have enough insulin to get the sugar into your cells, your body's like just floating around with really high levels of blood sugar. Okay. So your body tries to get rid of it by making you thirsty. Okay, and when it makes you thirsty, it causes you to urinate more. So now you're urinating out the excess sugar. The problem is your cells are still screaming for energy and for fuel, so now you're extra hungry. Okay, so it becomes this vicious cycle of like, cells need energy, sugar can't get into cells, body's trying to get rid of sugar, eat more, drink more, pee more, back to the beginning, and it just keeps going around and around. These patients are usually insulin dependent. Come on, there we go. So type 1 diabetics are actually much more rare than you would think. Type 2 diabetics are really kind of taking the reins of the whole shebang. Type 1 diabetics are your insulin dependent children, or juvenile diabetes kind of. Most of the time this is found out relatively early on in their life. They'll be insulin dependent. Basically they don't produce enough insulin, as opposed to type 2 diabetes where your body is like has been desensitized to the insulin. Either you have too few insulin receptors or you don't have enough receptors that are working. Okay, your body can up and down regulate receptors, so when you have type 2 diabetes, it's the receptors are there, but they're not doing enough, or they're not getting it in into the cells. There's another thought that it is like they're getting enough of the sugar in, but you still just have way too much sugar. Most of these patients are older and tend to be obese with quote unquote metabolic syndrome. Metabolic syndrome is a triad of issues, which is high blood pressure, diabetes, and high cholesterol. Okay, they tend to live together. You really aren't seeing pure uncomplicated hypertension anymore. It seems to be running around with high cholesterol and diabetes. I would really love to move forward. So here's your metabolic syndrome. Another thing that usually you'll see is polycystic ovarian syndrome. The problem with this is it also increases the risk for dementia as well as cancer. Okay, come on. But your three primary ones are heart disease, high cholesterol, type 2 diabetes. Thank you. Other types of diabetes that are around that you might see are gestational. A woman who has gestational diabetes is at an increased risk of developing type 2 diabetes afterwards. Genetic and/or autoimmune disease or defect of the beta cells or the insulin itself. Pancreatic disease or damage, so you can have patients who might have been in a traumatic incident that damaged their pancreas. Excessive cortisol, which works against insulin, right? It's promoting too much of glucagon release, which could then result in high levels of sugar. Glucocorticoids also can induce diabetes. There's a lot of different things. Genetic syndromes like type 2 diabetes and Down syndrome are very closely related. Okay, this in general, like you see a lot of genetic syndromes that have diabetes, type 2 diabetes. Diabetes is really damaging to your body as a whole, especially if you don't control your blood sugar very well. It causes a lot of neuropathies. It causes like loss of vision. It causes high blood pressure. So as your sugar increases, you start to metabolize fats. And as you start to metabolize fats, you end up with ketones, as well as atherosclerosis, because all those fats start to be deposited in your vasculature. And you start to have muscle wasting. Because again, remember, protein, your muscles are the first things that start getting broken down in order to produce energy, because your body will demand energy. So they used to actually, back in like the Egyptian times, they would test for diabetes by drinking other people's urines, because if you have glucose in your urine, it's a good probability that you are diabetic. The problem with glucose in your urine is that glucose is a very large molecule, and as it floats around in your blood, it causes some damage, but then it goes into these very delicate the nephrons in the kidneys, which are very delicate, and it just blows holes in them. This is why you see patients with diabetes or poorly controlled diabetes who tend to be on dialysis, okay, or in kidney failure, because they didn't do a good job taking care of their sugar. They've blown holes in their kidneys. It's easy for diabetics, especially poorly managed diabetics, to get dehydrated because those large molecules, right? We talked about how your body wants to be in homeostasis. A large molecule is going to attract a lot of water along with it, so you will be dehydrated quickly. As you start to move into that ketosis, right, as your body starts to break down fats, you start to become more acidic, okay? This is when you start to see the patient having those Kussmaul's respirations, right? They're breathing really hard. As the ketosis or the ketone bodies start to be out and about, you start to the cells start to release potassium into the bloodstream. So now you have acidosis combined with high potassium. It's a disaster. Okay, so your body's acidic, which is not a place it wants to be, and now you're hyperkalemic as well. So you're going to be prone to cardiac dysrhythmias. But it's hard to fix a cardiac dysrhythmia in the presence of acidosis. Okay, so it's just overall not a good look for the body. We talked about most of these already, right? The chronic complications of diabetes, okay? Blindness, kidney disease, all of these issues, patients who have diabetes, especially poorly managed diabetes, are at increased risk. Different types of insulin, okay? You're not necessarily going to need to know these, but you should be familiar to, for a certain effect, a point where you will see that patients will have a rapid acting and a long acting insulin. So basically, they'll give themselves like a long acting insulin every morning, and then they'll take a rapid right before they eat. The problem is if they screw up their insulins. Okay. I had a lady once who flip-flopped her daughter flip-flopped her insulins by accident, so she took like multiple long-acting insulins right before her meals and took a short-acting in the morning, and her sugar was not coming up. So, this is, patients need to be really careful with their medications. Insulin pumps, okay, there are some patients who they do this. They try to keep their sugar in a very controlled range, and they use these um, vicious looking needles. Okay, so they leave these on for, I believe it's about 3 days. They have to change the needle every couple days, and there's a cartridge in that little pump of insulin. So it's giving them a regular flow of insulin as if it was their normal body's mechanisms. Okay, but then they can also give themselves a bolus after eating so that they don't have these spikes, because the spikes are what's dangerous. The problem with this is if the battery dies, or they can't afford a cartridge, or if they forget to eat, okay, then you have patients who end up with all sorts of issues. If you're trying to revive a insulin pump patient whose sugar has been low, you might want to consider turning their pump off for the time being until you get them back into a range where they can then turn it back on, okay, because be giving them sugar and sugar and sugar, and they're not going to come back around because their pump is still giving them insulin on the other side. Type 2 diabetics tend to be on oral hypoglycemics because they still have functioning beta cells, but they just have downregulated their insulin receptors. You'll see a bunch of these. They have all different names. The most common is you see glipizide and metformin. Metformin is considered to be relatively safe. Glimepiride's also in there. I think glimepiride is the preferred medication. Glimepiride or metformin are preferred during pregnancy for those with gestational diabetes. Okay, it's just there to try to help support the body's natural functions to get the sugar into the cells. I will tell you, diabetic emergencies, when they're hypoglycemic, tend to be the ones who want to RMA the most. Okay, so don't be surprised if you wake up somebody who's a diabetic and they're like, I don't want to go to the hospital. They need to start eating some real food then if they would stay home. Most of the time you have diabetics who took their insulin, just either forgot to eat or exercised more than they usually do. Okay, those two activities, especially when it's summer and it's hot, that will tip them right over the edge into, a low end sugar reading. Other issues could be like chronic alcoholism, where they don't have glucagon storage, right? Your alcoholics don't have good glucagon because their liver's too busy detoxifying them. Anybody who has any sort of liver disease, right? Because you're not able to use that liver for storage. Cancer is just a disaster. In general, sepsis or infection, okay? Patients can become hypoglycemic. I've seen most diabetic patients actually go on the hyperglycemic side as they become septic because their body's releasing cortisol. Okay, so it's going to start releasing more sugar in the system. So some signs and symptoms of hypoglycemic patient might be kind of shaky, diaphoretic, pale, just generally feeling not well. Okay. It's much more preferable. I know a lot of other regions are switching from the D50 ampules to D10 because they don't want to spike the patient's blood sugar that much. And even though it is considered an emergency, D10 is adequate to, calmly elevate their blood sugar without putting them way over the edge and like up to 300 or whatever. That's really going to cause them issues. Yes, Nassau and Suffolk are D10. The city's still catching up.
I think aren't all the collaboratives D10 and the city's D25?
I don't think the city switched to D25 yet. I think it's still D50.
I think they. Well, let me check because I don't think
Yeah.
it's. Yeah.
Yeah, city's still D50.
Still D50.
Yeah.
Ooh, I haven't done any city rotation, so I haven't really paid that much attention.
They use D25 for kids.
For kids, we had somebody at hypoglycemic last night at 26 who ran his car into a tree because he was hypoglycemic.
Whoops.
The D10 in less than 3 or 4 minutes of running had him back up to 98. So
yeah, it's a lot more gentle. Diabetics definitely don't like it when you give them D50. It's really rough on their system. It takes them a while to then balance it back out. So, diabetic ketoacidosis, DKA. Okay, the body. This is usually your patients if it's your type 1 patient. They're unable to get the sugar into their blood, into their cells. So their circulating blood glucose starts to rise. While that starts to rise, the cells are screaming for energy and they start burning fats. As they start burning fats, it releases ketones as a byproduct, and the acidosis causes the potassium to start leaking out of the cells. Which, keep in mind, any sort of acidosis can cause potassium to leak out of cells. This is why your cardiac arrest patients could re-enter dysrhythmias. So there's a whole slew of other things that can cause diabetics to kind of slide into this diabetic ketoacidosis side when they're not using enough sugar. Most of the time in this country, it's a failure to take insulin because they can't afford it, which is troublesome. Other, reasons are that they have been undiagnosed. They have some sort of increased stress or infection on the body, right, where the cortisol is now contributing to an increased amount of glycogen into glucose release. Pregnancy is a possibility, or an inadequate dose is because they haven't gone to the doctor or haven't updated their medications. So, right, we still have our 3 Ps: polydipsia, polyuria, polyphagia. The problem is that these patients are also nauseous and vomiting. DKA patients also tend to have GI bleeds in association because now the acidosis is causing damage to their cells. They will have what's called a ketotic breath, which is supposedly smells like acetone. I've never personally smelled it. And then they'll be tachycardic and hypotensive. They will also be super dehydrated. Okay, so these patients are going to require significant amounts of hydration. Okay, it's like a few liters by the time all said and done. Remember, if you do end up intubating these patients, do not take away their compensatory Kussmaul breathing. You will make their acidosis worse. You want to make sure you're still breathing at an adequate rate and depth to help them blow off the acids. Similar to DKA, but without the acidotic part, is hyperosmolar hyperglycemic non-ketotic syndrome. This is your type 2 version of DKA, okay? So the body is able to get sugar into the cells, but not as much as it needs to. So you have high sugar levels. The cells are still getting their sugar. They're not breaking down the fat, so they're not getting acidotic, but their sugar's through the roof and they're super dehydrated because you have those large molecules of glucose floating around, punching holes in kidneys, dehydrating the bejesus out of them, okay? So they're still just enough insulin to maintain life and function, but not enough to make sure that everything that's in the bloodstream is getting into the cells. The problem with both of these, DKA and HHNS, is the dehydration, okay? That's going to cause them to be at higher risk of having clots because of the severe dehydration. So keep that in mind because you might also have someone presenting with a neuro problem like a stroke. You must assess your glucose, VGL, before you give a patient glucose. Because it might not be a sugar problem, right? Maybe it's narcotic, maybe it's something else. It's also really good to make sure that when you check their sugar and you give them or some sort of glucose, that it then goes up, okay? So oral glucose should be administered first if the patient is awake and alert, okay? Especially because these patients are probably going to want to RMA. And if they're going to RMA and you've already started an IV, they're going to be grumpy, okay? Also, it's a little more natural, a little more controlled for them to eat the sugar instead. Glucagon is available for IM and IN if you cannot get the patient to get an IV on the patient. But again, remember, it's gonna take a while for it to work. And if they're a fragile diabetic or an alcoholic, it's potentially not gonna work at all. Hyperglycemic. You want to hydrate these patients. You absolutely do. You want to see if there's something else going on as well. So these are the patients who require close cardiac monitoring because if they have really bad peaked T waves, they might be going into VTAC or VFib because of the hyperkalemia. This might be a patient who you would want to call and ask for bicarb for. Okay, it might help reduce the acidosis depending on how bad they are. This is a patient you might want to get calcium for because the calcium will counteract the potassium. Okay, so diabetics also, you want to see if there's an infection source. Take their socks off, okay? Because if you can find an infection source, you might know exactly what's going on. All right, thyroid. Hypothyroid is probably the most common problem in the United States at this time. Synthroid is the #1 most prescribed medication. It has been for about 3 or 4 years now. Your thyroid lives here. It regulates your metabolism. It does T3, T4, and calcitonin. So calcitonin plays nice with the parathyroids and moderates how much calcium is in your blood. Thyroxine and T3, because I'm not going to try to say that right now, help with metabolism overall. It responds to other parts of your body. I had a thought, lost a thought. All right. Again, shock and surprise, women are extremely more likely than men to have thyroid problems. The older you get, the more likely women will have a thyroid issue. The problem with undiagnosed, it's most commonly hypothyroid. It's most commonly due to autoimmune or some sort of tumor or nodule that's found that's causing the person to have part of their thyroid removed. There is a axis within the systems called the hypothalamic pituitary hormone system. Okay, it helps regulate a lot of your metabolism. So patients who are hypothyroid will have heart disease, will have weight gain, will be regularly cold, will have very brittle bones because remember it also helps regulate calcitonin. Your bones need calcium. So if you are having issues with your calcium, you're going to have weakened bones. There's this whole thing right now where they're talking about the lab values for thyroid and how you can have hypothyroidism without clinical values that actually show on blood work that you have hypothyroidism, which is pretty wild because you can be really sick for a while and not even know it. Most of the time, you also have things like thin skin, thin hair. A lot of issues like that are associated with thyroid problems. Again, because it's kind of factors into your metabolism. If you're unable to metabolize enough of the right things, you're not going to have healthy looking skin and hair. On the other side is hyperthyroid. Okay, hyperthyroid is a little more rare. You have a very high metabolism rate. Okay, this is usually seen in thyrotoxicosis. Thyrotoxicosis. There you go. It's usually very relatively rare. or not rare, relatively common, but it's mild. Okay, so your patient will have a little bit too much of hypothyroid going on. The problem is when it gets triggered into a hypothyroid storm. Again, stress in your body can cause a lot of different things, and that could cause extremely high body temperature, which is really what is the problem in thyroid storm, and tachycardia. Okay, um, it starts again to trigger that fight or flight. Um, so it just ends up being life threatening. Thyrotoxicosis, you'll see patients who have the bulging eyes, which is called exophthalmos. There we go. Or they might have a goiter, okay, right? That bulging out in the neck. Commonly seen in, here's your hyperthyroid, right? So you have the bulging goiter. The eyes, they don't look like that. That looks like a really crappy filter. It's actually like one of those toys that you squeeze and the eyes pop out. That's kind of what the bulging eyes looks like. Hypothyroidism is treated commonly with Synthroid, which is synthetic T4, okay, because the body is not making enough of it. It's not stimulating either there's too much, the body's stimulating the thyroid, but it's not actually responding, so it needs to be replaced. Shock and surprise, more common in women. If it's not treated, or if someone stops taking their Synthroid, what can happen is they can go into what's called myxedema. I have seen it once. Basically, the thyroid stops really working, and the skin starts to get really thin and kind of, it's called mucinous, but it's very like squishy, like it's fluffy and squishy. The patient's very, very cold. They'll have a reduced level of consciousness. Think of a nice picture. So here, the lady on the same lady, right? Look how thin her hair is, right? So her thyroid was not working. She had myxedema. So this is kind of like, see that like that fluffy, pudgy kind of look of her eyelids right there? That's I could tell you right now, she is ice cold to the touch, this lady, most likely. Other skin breakdown, and then when they fix and correct her thyroid problems, she actually looks like a normal functioning human being again, right? And her mental status improves. It's kind of wild. Then you have your adrenal gland issues, all right? It's Cushing's and Addison's. There you are. There they are, Mike. Adrenal glands live on top of your kidneys, like Smurf hats on top of your kidneys. They are triangular. They live on top of your kidney. The medulla, which is the inside, produces epi and norepinephrine, whereas the cortex, which is just the outermost ring, produces cortisone and aldosterone. So cortisone and aldosterone help balance your fluid and electrolytes, and also aldosterone participates in regulation of your blood pressure. Okay. So Cushing's syndrome is when you have too much corticosteroids. So your adrenals are overdoing it. Okay. Look at that. Again, women being primarily affected by this. Tends to have either an autoimmune component, or there's an adrenal gland tumor that's causing too much of the hormones to be released. Steroid use is also in there. Steroid use being in there as usually a treatment for autoimmune diseases. So it all goes hand in hand. So patients will usually present with what's called a moon face. So their face is very pudgy, very fluffy, and a buffalo hump. Anyone remember Young Frankenstein? Igor has the hump. Big hump right there on the back of the neck. The patient will be usually very plump in the middle, but really thin skin or thin limbs. Diabetes, right? Because now too much cortisol is increasing their sugar. They'll have a lot of body hair. So a lot of different things. Here's that moon face look. She's got the facial hair. She got a mustache going on. She's got those striae stretch marks across her chest. Okay, this is kind of what Cushing's syndrome looks like. On the other side, you have Addison's. So Addison's is relatively rare. Okay, it usually is caused by something that's damaged the adrenals. Okay, cortexes of the adrenals. So it's not giving you the steroids or the cortisol and the aldosterone that you need. Okay. So you don't respond well to stress because cortisol is your stress hormone. Okay. You have severe stress will cause issues. The problem is it's also now affecting your fluid and electrolytes. So patients who go into Addisonian crisis will third space fluid. Okay. So they will be super hypotensive and full of edema because their body just goes, can't deal, and then sends the plasma into that interstitial space. A lot of the times, the patients will be kind of on the thinner side. They'll be hypotensive because they're not managing their fluids well. Again, they're hyperkalemic and hyponatremic because they can't balance their electrolytes great. And they'll also have skin hyperpigmentation, so they'll look bronze. We can treat Addisonian crisis in the field. There was, up until a few years ago, an actual protocol in Nassau for Addisonian crisis. They had everyone carrying 100 milligrams of Solu Cortef, which is essentially just prednisone in IV form. You can treat Addisonian with Solumedrol, but now in most places it's become a medical control order because it's kind of more on the rare side. And it's easier for you to call and say, hey, the patient has a history of Addisonians or congenital adrenal hyperplasia or something else that would cause them to have a crisis. So usually it's triggered by a significant stressor, right? It could be an injury, it could be literally just psychological stress, and the patient becomes extremely dehydrated, the blood volume transfers into the third spacing, and they need the steroids to kind of re-regulate their body. It was thought that JFK actually had Addison's disease because he was just always so bronze. So again, you'll have changes in the distribution of facial hair, cortisol, and cortisol has a lot of effects on facial hair in general. Patient will be, as opposed to in Cushing's where they're very plump, they'll be very thin, okay? Hypotensive. Oh. Questions, thoughts, concerns, recipes?
Nicole, can someone develop Addison's disease if they only have one kidney? Let's say they donated one.
Sure. Good question. I don't know. I have to get back to you on that one. Any other questions? Well, studying. I know you have your test.
I actually have a quick question. I'm sorry.
No worries.
So if a patient's hyperglycemic, like let's say over 500, error on the machine, ALS arrives, what kind of like is running through your mind? Like, what do you kind of, what's like your treatment? I had a patient like that one time, and like medics again kind of didn't really know, or it didn't really do anything. But I thought you kind of gotta like just give like fluids.
Yeah,
right?
fluids.
Just fluids, right?
Fluids and cardiac
Keep it.
monitoring.
Got it. All right.
Because you
I
wanna
always
make sure
thought that there was just more
yeah.
to it, because the protocol says like if it's over 500 and they're like AMS or something, you know.
You give
but
more fluid.
more
Yeah, no,
fluids,
yeah, you give a little bit more fluid.
just a little more.
A little bit more. It's really it's just fluids. So basically what happens, those patients are going to get admitted to the hospital and they're going to be put on an insulin and D5W drip, because if they plummet their sugar too quickly with insulin, you're going to put them into a dysrhythmia. So they have to be really careful about how they lower their blood sugar, and they have to like constantly monitor to make sure they're not doing it too quickly, which is why we don't do insulin in the field, because it needs to be carefully balanced with hydration, electrolyte monitoring, and sugar monitoring.
Oh, got it.
Yeah.
Alrighty. Thank you for that.
You're welcome. So hydration is the answer. I don't know. I have no idea why we don't do banana bags. All right. Well, I know you guys have your test on Wednesday, so good luck on your studying. And if you have any questions, please feel free to reach out. Other than that, have a lovely day.
Thank you, Nicole.
Thank you, you too. Thank you.
Thanks.
Nicole, take care.
Thank you.
Thank you.